Ma'am, we are live. Let me play the series of coordinators and chairpersons. Ma'am, you can start now.
Yeah. On behalf of the team Women Endocrine Care, We Care, I would like to give a warm welcome to all of the delegates who have joined us today and will be joining us tomorrow. It's really an honor and a privilege to have such exemplary faculty with us on both of the days. The focus of the entire We Care is to focus on women endocrine issues, and there is no better week than to do it for the International Women's Day week. So without spending much time, I would like to invite the session coordinators for our first session, and that is Dr. Jayashree Gopal. She is a diplomate in internal medicine, endocrinology, and diabetes from US. She is the director of Endo Care India Chennai, and a very warm personality, very academically oriented. And our second coordinator for the first session would be Dr. Usha. Can we move the CV slide, please? Dr. Usha Yagri is also an endocrinologist, a consultant in Apollo Sugar Clinics and Apollo Specialty Hospital, Proton Cancer Center, Chennai. Again, very internationally accomplished in terms of both academics and a great clinician. So I'll hand over the session to Dr. Jayashree and Dr. Usha.
Thank you very much, Gagan, and good afternoon and welcome to all who have joined us today. This first session this afternoon in this hall is on thyroid disorders in women. Because we all know that thyroid problems tend to be picked up more commonly in women. We've lined up a series of talks which address some topics which are somewhat controversial. And there is always a lot of debate among us endocrinologists about these topics, and I hope you find the sessions that follow useful. It gives me great pleasure to introduce the chairpersons for this session, Dr. Shubhakant Chaudhary, who is the professor and head of the Department of Endocrinology at IPGMER and SSKM Hospital. He's also held a number of other, official positions. He's currently a member of the Subject Expert Committee of the CDSCO of the Government of India. He's also a founder patron of the SAFES, chairman of the RSSDI West Bengal chapter. He was the past president of the Endocrine Society of India, under whose aegis this whole conference is being held. And his current research interests include gut microbiome and the pathogenesis of grapes. The next slide, please. And also gives me great pleasure to introduce Dr. Professor Kalpana Dash, who is the Chief of Diabetes and Endocrinology at the Apollo Hospitals in Bilaspur. She's also an adjunct faculty at the AHERF, and she's also a national faculty for the PHFI for diabetes and thyroid courses. She's an honorary faculty at the Texila American University for the MSc course in endocrinology. She's an editorial board member of the Apollo Medical Journal, and she has several publications and is a very prominent figure on our endocrine conference network. It gives me great pleasure to welcome such distinguished faculty to our conference, and I turn over the session to them now.
Thank you very much. Good afternoon to all of you, and it's a great pleasure to be part of this We Care conference. I'm sure it's going to be learning for us as well. And when we talk of thyroid disorders, of course, it's much more in women than in men. When we talk of diabetes, it's almost 50-50, though of course there are specific issues, important issues relevant to women. And this afternoon we have excellent topics to talk on, and nice titles, dressy titles as well, exciting titles as well. And to top it off, we have wonderful speakers. So why stay away from them, from the topic proper? And maybe Dr. Kalpana Dash, if she wants to put in a word, then otherwise we will go to the first topic with Unni.
Yeah, we can start the program because otherwise we'll waste time. So thank you so much, sir. Thank you, Jayasree, and thank you, Usha, and all the organizing committee members. Thank you, Gagan, also. So I am very much privileged to be a part of this national meeting and the Women We Care program. And we have excellent topics today, and especially the thyroid topics. They are very exciting. So I think I hand over to you, sir. You can introduce the speakers of today. The first
speakers are possibly better known than myself.
Yeah, I know.
But still,
I know.
But yes.
But we have to read it out.
Yeah. No. Still, do we have a slide? But Dr. Unnikrishnan
they have it. Yeah.
Right. Yeah. So Dr. Unnikrishnan, of course, is the CEO and Chief Endocrinologist at Cheldaram Diabetes Institute. He has had a marvelous career academically, professionally, has had numerous awards to his name, and has been a prolific at publications, over 200 PubMed indexed publications, and he's editor-in-chief, Chronicle of Diabetes Research and Practice. He was a former chief editor of Journal of Thyroid Research and Practice, and not only is he an excellent speaker, which we all know, which we will again find out, he is also overseeing a lot of philanthropic rural diabetes care program, which I must say, I do not myself can claim that I oversee a lot of this. So over to Unnikrishnan, and maybe we are past the age of eponyms. We, in our exam days, maybe one used to be asked about von Graf sign, Mobius sign, this, that related to Graves or vitopathy. But nowadays, these are gone. And so Unnikrishnan will take us through as a next-gen endocrinologist to whatever we should call Hashimoto's thyroiditis. Over to you, Unni.
Thank you, sir. Thank you, sir, for those kind words. Thank you, Dr. Dash, and of course, Dr. Gagandeep, Dr. Gagan Priya, Dr. Jayashree Gopal, Dr. Ayagiri, Dr. Jabba, Dr. Maitli, all of you. Thank you so much for the invitation. Let me just share my screen. I hope my screen is visible and I'm audible.
Absolutely.
So let me go ahead and present my talk, which is, as Dr. Shubhankar Chaudhary said, titled very fascinatingly, Is It Time to Retire Hashimoto's Thyroiditis? And this is going to be my agenda. My first part is going to talk about The King is Dead, Long Live the King. A very catchy title because, if it begins with the same two words that it ends with, and that's the reason why such phrases are very popular. The king is dead, long live the king. You could also say a rose by any other name is still a rose. So let me talk about Charles VI. And this is a picture of Charles VI. And when he was very young, at the age of 11, he ascended the throne, and then he had a series of battles. And he also was a person prone to a lot of moody swings, and he fought battles and he had ups and downs in his moods, and very interesting person. But what is the connection? What is the French connection, and what does this have to do with Hashimoto's thyroiditis and time, whether it's time to retire Hashimoto's thyroiditis? And what does it have to do with International Women's Day, which was just over? I will come to that in a moment. So let me now talk about Dr. Hikaru Hashimoto. Dr. Shubhankar said that it is nowadays people don't look at eponymous titles, but I think there is a case not to retire Hashimoto's thyroiditis, because the life of Hashimoto has been instructive in so many ways. So my next few slides, I will talk about Hashimoto, Dr. Hikaru Hashimoto. So I wrote about Dr. Hikaru Hashimoto in the JAPI. I was invited to write an article of Dr. Hashimoto's contribution, and you will find the reference here. The story of Hikaru Hashimoto's life is worth telling. Of course, you can see a picture of a road here, a street called Hashimoto Street. Japan also honored him with a stamp. And Dr. Hashimoto was very unique because he was one of those people who lived for a very short period of time, but when he lived a magnificent life. So just before he left to Germany in 1911 or so, he published a treatise on biopsies of the thyroid with lymphatic infiltration as the pathology. And in 1912, he moved to Germany, worked there for 3 years. And after working there for 3 years, very unusually, people who migrate to Western countries rarely come back to their village. But 1915, with the onset of the World War, the First World War, Dr. Hashimoto came back, and then he moved to his original village in Japan, and he was seeing patients like a family practitioner. So a doctor from a family of doctors, generations of doctors, published very important work in thyroid, went to Germany, worked on this field, worked on pathology, came back to his roots, came back to his very village. And it is said that he would travel from house to house on a rickshaw and treat patients. And it is also said that he never took money from poor patients. And sometimes critically ill patients, he would, with just the help of a nurse, he would operate them. So he returned back to his roots, not just his roots in Japan to his village, but also to the roots of every doctor, because at the end of the day, we may be endocrinologists or nephrologists, but at the end of the day, we are doctors, and he went back to his general practice or family practice and took care of people in his community. So very unusual life. And on one of those trips in 1934 to visit a patient on a house call, that's probably when he got typhoid, and he actually succumbed to typhoid fever, and he died at a very young age. I think he was born in 1981 and died in 1934. He was born in 1881 and died in 1934. So very short, eventful life, and did a lot of things in that short period. Now let's go on to the resurrection of Hashimoto's thyroiditis. Hashimoto described the disease, no doubt a magnificent discovery, and even today the disease is being invented and reinvented in so many ways. This is a study, very recent study, and this study, I mention it because this study is mentioned in the latest edition of the Williams textbook of endocrinology, saying that seronegative autoimmune thyroiditis displays a milder clinical picture. The authors studied people with classic autoimmune thyroiditis and classic autoimmune thyroiditis, which is seronegative, or you can say chronic autoimmune thyroiditis. And here, what the authors found is that people who were seronegative had had a higher free T4, had a lower TSH, lower prevalence of subclinical hypothyroidism, and a lower thyroid volume. Whereas people who are seropositive, anti-TPO positive chronic autoimmune thyroiditis have a lower free T4, a higher TSH, suggesting they have a more severe disease. So even today, the disease is finding invention and reinvention, and that's why I said the king is dead, long live the king. These are some of my publications in the field. You can see that subclinical hypothyroidism, this is Indian data, is present in 8%. This is, of course, I reviewed this, but this is paper by Dr. Marwa, that 7.5% of 764 schoolgirls had lymphocytic thyroiditis, very common. The prevalence of hypothyroidism, overt hypothyroidism, is about 3.4%, and the prevalence of TPO positivity in adults is about 9%. And overall, the prevalence of anti-TPO positivity is quite high. So whether we call it Hashimoto's thyroiditis or chronic autoimmune thyroiditis, the disease just still exists. And even if you look at gender differences, if you just look at data from the 8-city study, which looked at 5, 3, 7, 6 subjects, hypothyroidism was commoner in women than men. The odds ratio was 3.36. The confidence intervals ranging from 2.7 to 4.14, and a significantly higher number, a statistically significantly higher number of females compared to males were detected to have subclinical hypothyroidism. This is another recent paper. I show this to say that the understanding between Hashimoto's thyroiditis and neoplasia, and there is still ongoing research on this topic. This is a meta-analysis published in December, which looked at the association between malignancy. And there is a statistically significant link between all thyroid malignancies and Hashimoto's thyroiditis. As I show you, the odds ratio is about 1.36 and the range between 1.05 to 1.77. Papillary thyroid cancer is linked, medullary thyroid cancer is linked, and we are all aware that lymphoma is linked, the odds ratio being 12.9 fold, not really percentage, 12.9 fold is an odds ratio out there. So again, showing you that Hashimoto's thyroiditis continues to evolve in different directions. Just to correct, these are not percentages, but odds ratios here. But follicular and anaplastic carcinomas were not linked to Hashimoto's thyroiditis. So it's important not to retire Hashimoto's thyroiditis because it's the commonest cause of hypothyroidism associated with malignancies, and iodine supplementation is probably changing the spectrum of the disease. And let me go back to my original set of slides, which looks at the story of Charles VI, and then I'll conclude. So as I said, Charles VI, he came to power when he was 11 years old, and he fought battles. And interestingly, he fought a battle where he had these feelings of paranoid feelings. And it is said that he also was not well mentally. And at one point, he attacked his own people. And that's really reminiscent of an autoimmune thyroid disease, where the body attacks its own gland. And could he have had Hashimoto's encephalopathy? Right? One never knows. One even questions today the existence of Hashimoto's encephalopathy, but one never knows that. But just to conclude, Charles VI was replaced by Charles VII and today we are also celebrating International Women's Day and Women in Endocrinology by none other than Joan of Arc, who put Charles VII on the floor of Charles on the throne of Charles VI. And that is where the term came, the king is dead, long live the king. So Hashimoto's thyroiditis, you can call it by any other name, but Hashimoto's thyroiditis as a disease continues to exist and will continue to exist. So friends, I come to the last slide. I'd like to say that it's not time to retire Hashimoto's thyroiditis. You can call it by any other name, but the disease still exists and is finding new ways to change thyroid sciences. And my personal view is that we should celebrate the life of Hikaru Hashimoto, and very tragic end that he died of typhoid, a disease that's so curable today. And also a fascinating story of a person who reached a pinnacle in science as a doctor, coming back to family practice and looking after the needy in his area. Finally, the disease is very much there, Hashimoto's thyroiditis, but continues to re-exist and resurrect itself in many other ways. And thank you, friends, for giving me the opportunity to be with all of you, and also taking this opportunity to remember Joan of the Arc, who was a lady who was a powerful ruler in those times. And this is a salute to all the women scientists and women physicians and endocrinologists. And let's hope the future decade shows more involvement of women in science because they are better scientists and doctors than men, studies have shown. So over to you, sir, and thank you for the opportunity to be here.
Thank you very much, Uni. I suppose there aren't any competitors to Hashimoto. For example, for Grave, you may have Paddy, Besdow, other people were also there who described or involved. So I'm not aware. So Uni, would you know, are there any other competitors to Hashimoto in that regard?
As far as I'm aware, none except for the study by the Shepherd's group, which showed that TPO positivity doubles the rate of progression from subclinical to overt, which really cemented the place of. But otherwise, I'm not aware of anybody who can, take the place of Hashimoto in this. So I don't think its competitors are there. It's not like, for example, insulin, which is, there was such a huge battle for the Nobel Prize.
Yeah. So I don't know, Gagan, what did the organizers have in mind when you put this title or this topic? Of course, dealt very well by Unni with actually the story. The first name, Hakaru, of course, I was reminded by Unni only. We all talk of Hashimoto only, but he provide us the full name, Hakaru Hashimoto.
Yes,
yeah.
Hi, Unni. There is a question from Gagan Priya. Some patients are TPO negative, but anti-TG positive. What is your view on that?
So in my view, anti-TG positivity is seen in a larger proportion of the population, and anti-TPO is a more specific one. But of recently, there are some reports that anti-TGO is also a good predictor of autoimmune thyroid disease. But because of its high occurrence even in the normal population, I really don't look at anti-TG antibodies, except of course in follow-up of thyroid cancers, where you take a serum thyroglobulin and an anti-thyroglobulin antibody from the same sample during the follow-up of, say, thyroid carcinoma. But thank you for that question.
I have one question, although maybe this is out of the topic. How do you differentiate between TPO and TRAB, the role of both the antibodies in case of Graves' disease? The TRAB and the TPOB. So
I like out of the syllabus questions because I always say that I don't know the answer. But I think, ma'am, it's a very good question because I think many of the TPO negative autoimmune thyroiditis could actually be TRAB, TSH receptor antibody blocking antibodies may be at the root cause. We are not very sure. Many years back, with Karolinska Institute, we did a small study looking at TRAB in type 1 diabetes, and we found that TPO and TRAB identified different subsets of autoimmune thyroid disease within the spectrum of type 1 diabetes. But the number was very small. We studied only 83 type 1 diabetes people, and the paper is almost now 16, 17 years old. So I strongly feel that many of them could be TSH receptor blocking antibodies. But one thing maybe to argue against that could be that these blocking antibodies keep the epitope specificity keeps changing. So some of them, if it had been so, may switch to Graves' disease later on. So if you see a patient with Graves' disease becoming hypothyroid spontaneously without radioactive iodine, or hypothyroid becoming hyperthyroid again with Graves' disease, then I think we could think of this TSH receptor antibody, which may be blocking or stimulatory depending on whether the C or the N epitope specificity is there for the antibody. So this is my view about this matter. But I'm open because, as I said, this is out of syllabus, so I can say maybe somebody else can also answer. Thank you for that question.
Thank you. Thank you.
Professor Shubhankar, if I can just chime in. The reason why we wanted this topic is that this title of Hashimoto's, whatever it is, autoimmune diseases, are served by a lot of, first of all, I see it used a lot by nutritionists and dietitians who do antibodies and then tell their patients, oh, you have Hashimoto's, and they all come back looking very worried. And it's even within sort of the physician community. For example, I think there is a lot of misinformation. The way we think about Hashimoto's thyroiditis is not the way that, for example, maybe obstetrics and gynecologists or other non-medical specialties think about it. So that is the reason why I brought it up. It seems to be sort of some favored term which is being used now to blame a lot of ills. So they come saying they can't lose weight, oh, because I have Hashimoto's, or I feel ill, it's because I have Hashimoto's. So that's the reason why we wanted to, talk about what actually Hashimoto's means, and that is the reason.
So I agree with the point, but maybe, Hashimoto's thyroiditis, if we take off that term, it will be replaced by another term. They'll just say we have chronic autoimmune thyroiditis, and we are not losing weight. So I agree that maybe autoimmune thyroid disease with normal thyroid functions, that as a disease could be retired. I completely agree with you. Maybe Dr. Shubhankar sir can conclude also on that.
Sorry, antibody positive, but
So I'm saying
euthyroid.
antibody TPO positive or FNAC proven lymphocytic thyroiditis people who have normal thyroid functions, maybe that as a disease which some, as Dr. Jayashree said, some nutritionists and other people are calling it a disease. I think that we could make a strong focus not to call that into a disease unless there is biochemical evidence of high thyroid dysfunction. Maybe a thought from just, I thought of it from Dr. Jayashree's opinion.
Yeah, but of course, there would be a euthyroid phase before the patient becomes hypothyroid, and there could even be a thyrotoxic, transient thyrotoxic phase as well to this entire spectrum. So I think the point is well taken that we continue to have, we will have, continue to have maybe even larger numbers of autoimmune thyroiditis as iodine deficiency is taken care of across the globe. So as a disease entity, a concept, it will still be there. Whether we stick with the term Hashimoto's or not may be debatable. Of course, chronic autoimmune thyroiditis will remain, I'm sure all of us agree. And if it, if some patients like to be impressed by the term Hashimoto's, why not? And maybe Dr. Jabbar, quick word from you before you actually take on the stage.
I think it's a very interesting topic. I think there is another synonym also for that, Ward's disease. Okay, Ward, O-R-D-S. Okay, basically all these coming under the spectrum of autoimmune thyroid disease. Okay, whether you call it as Hashimoto, whatever thyroid it is. Okay, but the messages are very clear. Okay,
thank you. Yeah, sure. So would Dr. Kalpana Das now introduce the next speaker on the topic?
Can we have the CV slide deck, please?
So, hello everyone. So now Dr. P.K. Jabbar is with us, and he's MD GNB Medicine and DM, and he's the professor and the head of Department of Endocrinology and director and CEO of Indian Institute of Diabetes, Trivandrum. He's a postgraduate teacher and he's also a principal investigator, chair of ESICA in 2017. Also, he was the organizing secretary of RSDI 2010, contributed to various textbooks of medicine, 30 papers in journals, and presented papers in various endocrinology meetings, medical counseling inspector, and DNB professor also. So may I request Dr. P.K. Jabbar, and he will be talking on thyroid antibodies and this thing, all that charge. Yeah. Dr. Jabbar, please.
Yeah. I hope my screen is
visible.
Okay. Good afternoon, senior members, Dr. Kalpana, Shubhankar sir, Dr. Unni, Gagan, Jayashree. First of all, special thanks to VCare Group for the wonderful platform provided for me to discuss, as Dr. Jayashree said, full of controversy. Even after reviewing this article, I realized one thing. I don't know what is happening in clinical thyroidology. But whatever, I will review this. This is my basic agenda, basic case capsule, the thyroid autoimmunity, effects of antibody, and how to manage this issue. That's my simple menu for today. My friends, we have a patient, a real case, 34 years old female, complaining of recurrent abortion, now G5 and A4, thyroid function showed evidence of subclinical hypothyroidism. Now the crucial questions are one or two questions we should ask here. One, whether you want to treat this patient, what is the diagnosis first of all? Diagnosis, this could be a subclinical hypothyroidism. And very clearly it's written, you have antibodies or ATPOs are very, very significantly elevated. So you have a diagnostic label that is subclinical hypothyroidism, autoimmune thyroid disease, whatever terminology you want to use. You can use Hashimoto's, you can use whatever terminology, but so basically it's a case of autoimmune thyroid disease. You want to treat this patient, for this patient, especially giving lot of bad obstructive history, such a situation you want to treat or not? That's a basic question. If you look into the thyroid antibodies reason in bar at least 1 dozen of thyroid antibodies are available in the literature. But basically for our clinical purpose, we are using ATPO, anti-thyroglobulin antibodies, TSH receptor antibodies, which you can get in approximately 18% of pregnant women. See, all these antibodies, especially the ATPO, the maximum in the first trimester of pregnancy, and as the pregnancy progresses, the level will come down. So this is what is happening. So if you have positive antibodies, your TSH is elevated like this. And what are the antibodies which are freely crossing placental barrier? One is your thyroid releasing, it's not the stimulating. Anti-thyroid drugs, TRAM. The clinical implication, I think, is very clear for this August audience, that can produce fetal thyrotoxicosis and subsequently neonatal thyrotoxicosis. So if the patient has got antibodies in their serum that can cross the placenta, that can change the thyroid profile in maternal side also, which has got some positive negative impact on the maternal outcome. So if you look at the prevalence of antibodies, we have a lot of papers available in the literature. Basically, it's the range starting from 7 to 11 or 11.5%. These are the Indian data which is published in one of the journal here. Now, what are the clinical implications? Clinical implications, highly controversial. Here you can use two terminologies here. One is sporadic miscarriages, and patients can go for recurrent miscarriage. My dear friends, that one of the old paper published in 1994, multiple episodes of miscarriage, and here also meta-analysis also showed little significant increase in the prevalence of miscarriage, and recurrent miscarriage is also very common if the patient has got antibody positivity. So this is entire spectrum of the complication documented in various studies. One is anemia, which is also very statistically significant the issue. Preterm delivery also you have, fortunately there is no significant IUGR. Abruption, you remember the data, faster trial is available. Preeclampsia is also high. Gestational hypertension is also high. Postpartum hemorrhage is also high. So what I want to tell you that if the patient has got positive antibody, this carries lot of issues in maternal side. That's an important message. This analysis showed this is here you have recurrent miscarriages, subfertility here, recurrent miscarriage here. There are a lot of studies for that, and there are a number of complications. If you concentrate on this side, those who are having positive antibody, all these complications are high as per whatever studies we have documented in this paper. Now, meta-analysis, again, you can see this is one of the paper published in BMJ. You have subfertility, recurrent miscarriage. So what is the take-home message? Take-home message is thyroid antibodies, there is a risk of miscarriage also. Now, this is yet another meta-analysis which also showed if the patient has got antibody positivity, all these studies, you can start with the Muller study, Kutai study, Poppy study, Negro study. All these studies showed you have subfertility. Not only subfertility, abortion or miscarriage is also significantly elevated in presence of thyroid antibodies. Not only in the antepartum, in the postpartum phase also a lot of medical issues, including depression, placental abruption, which is also coming up in a big way, placental abruption as evidenced by Faster et al. These studies showed premature rupture of membrane is also significantly elevated. So these antepartum complications are carried into the postpartum phase also. We are not stopping here. These issues are translating into the fetal side also. What are the fetal issues? You can see here, cognitive disturbances, motor issues are there. As expected, probably little abnormality in the TSH, the IQ is also coming down. Affective disorder is also there. Autism is increased, and there are suggestions for increasing the incidence of respiratory distress syndrome also. So, my dear friends, ladies and gentlemen, what I want to tell you that if the patient has got antibodies that can produce antepartum problems, postpartum problems, not only postpartum, in the neonate and childhood also, you can have multiple medical problems. So what are the mechanisms for all those things? Basically, these the antibody mediated issues can produce little thyroid dysfunction. We are not picking up sometimes, so eventually that will escalate the issue. The cross-reactivity of antithyroid antibodies in the HCG receptors, so eventually the progesterone will come down, so chance for miscarriage is also high. Yet another mechanism is concurrent other organ-specific anti-autoimmunity may be there, and endometrial cytokine level is also high. The final result, or eventually, lastly, finally, they can go for miscarriage or abortion. Now, how do you sort out this issue? There are 4 methods you can have. One is levothyroxine. There are recommendations you can go for IV immunoglobulins. There are comparison between all those things. And there are physicians or gynecologists or obstetricians or infertility specialists. They're all giving steroids also. Let us look into the evidence-based medicine here. Now, this is one trial known as tablets trial, which is published in New England Journal of Medicine, which showed the use of levothyroxine in euthyroid women with antibody positivity did not result in higher rate of live birth. So what does it mean? This is a negative study, it's not a positive study. They are looking to the various aspects. The primary outcome was live birth, and they were looking to the other secondary outcome also. So in all phases, it was not showing its own influence in the complications profile. So they basically is a negative study. So to conclude, use of levothyroxine in euthyroid patient in presence of antibody, no much influence. That should be the take-home message from tablet study. This is one Chinese study published in British Medical Journal, which looked into the effect of this treatment. So what is shown here is a euthyroid state and the euthyroid with ATP positivity. The complications high, but it was not showing significant improvement with our treatment with the levothyroxine. Now coming to from the miscarriage, we are discussing about preterm delivery. Glenor, the first paper published by this author, significantly high risk for premature delivery than without antibodies. There are other meta-analysis also. All these meta-analysis, as Dr. Jayasri was discussing, very controversial paper. Negro, one of the famous author in this area, increased risk of preterm delivery compared to euthyroid ATP negative. So there are papers saying that there is a risk for preterm. There are papers saying that probably there is no increased incidence of preterm delivery. Now, this is one meta-analysis which showed most of the papers saying that there is a chance from preterm delivery. So it needs proper addressing of the issue during pregnancy. Now, this is one paper, the effect of T4 or altroxin in patient with the miscarriage and preterm delivery. You can see here, if the antibodies are positive, the frequency is very high, and miscarriage is also high. But if you are treating this patient, probably the effect, so-called miscarriage and preterm delivery will come down. That's a bottom line. You can read it from the altroxin treatment. In euthyroid ATP positive ladies, shows reduced incidence of miscarriage and preterm delivery. This is yet another paper which also showed, you can see the preterm delivery and the neonatal admissions, all these issues. If you are treating this patient, probably you can reduce the risk of preterm delivery if the patient has got antibody positivity and euthyroid. This is yet another meta-analysis. You can see the paper of Kapoor here, Glenor paper, Haddo's paper, Lijima paper, and Negro's paper. All these papers you can see here, increased risk of preterm delivery, those who are having antibody positivity. That should be the take-home message from all these papers. Now, again, paper saying that levothyroxine treatment, this is not during pregnancy, before conception, women with the thyroid antibodies, a step forward. So it seems this paper, this Negro second paper shows this may be useful, or levothyroxine treatment may be useful for reducing the fetal loss. You have another paper which is really coming up. So we have to wait for the result of L4 live trial. I think we will get the result. So there are other papers, but basically I want to discuss these paper, Negro paper and Nazarpur's paper, which also showed conflicting reports. One study shows positive report, another study shows negative report. I don't know what to do now. Even the tablet study, very well conducted study, no significant improvement in all these issues. Exactly, that's the reason Alexander et al. In 2017, they came with a recommendation. There is insufficient evidence to conclusively determine whether alprazolam decreases the pregnancy loss. However, administration of levothyroxine to ATP positive euthyroid women with a prior history of pregnancy loss may be considered. But I feel there is no harm in giving thyroxine. If you are giving small dose of thyroxine, even in the presence of euthyroid status, no harm. Definitely, I think I would recommend. I think most of my colleagues also will recommend very small dose of thyroxine for all these patients. Now, in Indian Thyroid Society and Gynecological Society, women with thyroid autoimmunity, euthyroid, early stage pregnancy, at risk of developing hypothyroidism, and should be monitored their serum TSH at least once and every trimester up to second trimester. I think it's very important to monitor your TSH, and thyroxine treatment can be considered in euthyroid pregnant women with antibody positivity and with multiple episodes of pregnancy loss. These are the recommendations by various scientific forums. Now, coming to most controversial paper, prednisolone in the treatment of pregnancy rate if the patient has got positive antibodies. This paper, Goxe et al., there is a strong relationship between presence of autoantibodies and poor outcome. So, co-administration of prednisolone definitely has got some rule for the better outcome, especially if the patient is going for in vitro fertilization. You have other papers also like Turi et al., which also showed if you are giving steroids with patients with a positive antibody, that gives a lot of comfort. You can see here, this limb is for treatment. This is without treatment. So with the treatment, the overall pregnancy rate is improving, clinical pregnancy is improving, live birth is increasing. So very positive paper. You can consider prednisolone for a patient with the ATP positivity. What I understood is a very small dose, is not a very high dose. You have another paper also, which also showed improvement if you are giving prednisolone. To summarize this study, the study showed that ATP positive women with the normal thyroid function, there is a close and strong association between presence of antibody and poor outcome. Although further studies needed for this for a definite conclusion, our preliminary experience suggests the prednisolone co-treatment may improve clinical pregnancy rate. So it seems a positive impact with the prednisolone if the patient has got antibody positive. Now let us examine the recommendation by American Thyroid Association and Endocrine Society. Basically, no support from any of the association and the American Thyroid or Endocrine Society. There are various things they are looking into, like in a sporadic miscarriage, what to do, recurrent miscarriage, what to do. There are recommendations for thyroxine, but no recommendation for steroids. Of course, if the patient is going for in vitro fertilization, this may be a useful modality. Now, concluding the remarks from Endocrine Society, American Thyroid Association guideline, euthyroid but positive antibodies should have measurement of TSH concentration performed at the pregnancy confirmation and every 4 weeks. If any change, definitely yes, ultrasonography has got a role, and still steroids we do not know. This is same if the patient is going for assisted reproductive technology. Treatment is indicated, especially if the patient has got deviation of TSH and the presence of antibodies. My friends, this is our patient's data. Patient ATP is positive, TSH is high. So our patient comes here. So patient needs treatment with the thyroxine. We are expecting good improvement if you are starting thyroxine for this type of patient. That's a take-home message from this slide. Now, screening is also recommended for autoimmune thyroid disease in women with a spontaneous abortion, and subsequently, you can treat the patient also with the thyroxine. Treatment with the thyroxine will reduce the necessity of assisted reproduction in achieving next pregnancy. Again, recommendations, very conflicting. There is no strong recommendation. ATA is keeping mum, endocrine society is also keeping mum for the screening aspects also. My dear friends, what I want to tell you that all these antibodies carries lot of clinical implications, especially miscarriage, preterm delivery. There are a number of complications also. But I personally feel that if you treat with thyroxine with a small dose, definitely you can save a lot of things, and you will get a good improvement. Thank you very much for that kind attention. Thanks for the attention. Over to organizers.
Thank you, sir. It's a wonderful talk and a very good revision for all of us. I think it's especially for me. It's a good revision, sir. That is antibody, thyroid antibody and pregnancy. So now the topic is open for discussion. But sir, I have one question, sir.
Yeah.
Is there any data on the IQ of the children born to the antibody positive euthyroid mother?
Yes,
as you said, there are incidences of ADHD.
Yes, madam, we have data. 100% we have data. It's not for hypothyroidism. Even simple antibody positivity, IQ derangement is documented.
Okay.
I think in the interest of time, we have to move on. Yeah. It's been a wonderful session so far. Thank you, Dr. Jabbar, once more. And we go on to the next part to talk about thyroid nodules, specifically in pregnancy. And we have with us Dr. Maithili, who is consultant endocrinologist at Visakhapatnam, formerly professor of endocrinology at Andhra Medical College, and is a founder secretary of Diabetic Child Society in Visakhapatnam, president-elect of Andhra Pradesh RSSDI, and has published numerous papers in index journals. So over to you, Dr. Maithili.
Thank you, sir. Thank you for the kind introduction. I'm honored to be a part of today's program. And I'm grateful to the team Women Endocrine Care for inviting me. So the session is on thyroid nodules during pregnancy. And to discuss, we have three esteemed endocrinologists as panelists. So we have Dr. Samir Agarwal, a leading endocrinologist and who's a president of the SPEED Society, a very distinguished society. He is an MCI recognized postgraduate teacher, has numerous credentials like recipient of the ESI A.V. Gandhi Award, and has written editor of so many books. Our next panelist is Dr. Harmandeep Kaur Gill, again a senior endocrinologist from Gurgaon. She has worked as an assistant professor in the Department of Endocrinology at UCMS Delhi. Our third panelist is Dr. Munashi Shahu, again from a consultant endocrinologist from Nayati Wimhan's Hospital, Delhi, and he has special interest in clinical drug trials. So I welcome all the three panelists for this discussion. So we are aware that the purpose of thyroid nodule evaluation is twofold. Number one is to diagnose any possible thyroid cancer, and secondly, guide appropriate treatment with minimal risks. And more so in pregnancy, it is important to take into account the risks and the potential contraindications of thyroid nodule management. So with this introduction, to start the ball rolling, so may I first ask Dr. Samir Agarwal to tell us if thyroid nodules are more common in pregnant women?
Thank you, ma'am, for nice words. Thanks to organizers, Dr. Gagan Priya and her team for inviting me. I think, yes, it seems whatever data we have from the epidemiological data we have for thyroid nodule incidence in pregnancy seems to be higher up. In fact, the latest, if we go through the ADA guidelines, they have a paper on this. They suggest a prevalence rate of somewhere around 3 to 21% of nodules, thyroid nodules in pregnancy, whereas if we talk about adult women, the incidence is somewhere around 5 to 6%. Of course, thyroid nodules are more common in women as compared to men, but in pregnancy, the incidence of thyroid nodule is varying between different studies, and it's around 3 to 21%.
Yeah, thank you. So, Dr. Harmandeep, can you please tell us if, Dr. Samir says there's an increased prevalence, and is there a tendency for nodule formation in pregnancy? And if so, should all pregnant women having pre-existing nodules, should they be evaluated again during pregnancy?
Yeah, so good afternoon, everybody, and many thanks for inviting me in this meeting. So regarding the whether there is any tendency for nodule formation in pregnancy, so if we see the normal physiology, like what is happening in pregnancy, we all know that there is increased requirement of hormone during pregnancy, and we keep on increasing the doses also. That is what we recommend, like for hypothyroid patients. So generally the requirement increases by around you can say 25 to 50%, and we also see the increase in thyroid volumes. So depending upon whether the patient belongs to iodine sufficient or deficient area, we see as per data, we know that there has been increase in volume by 10 to 30%. So going by that scenario and the hormonal changes which happen during pregnancy, we know there is increase in HCG and that mimics TSH, and there is increase in estrogen that also has direct or indirect effects. Like we know there are estrogen receptors also working in the thyroid gland. So all this environment seems like theoretically there is increased risk of nodule formation. And secondly, the studies also show, like Dr. Samir has told, like the famous Chinese study, they have seen like the nodules. There is the incidence of nodules was more during pregnancy, and it was rising actually as per trimester. That in as compared to first trimester and second trimester, there was higher percentage, and overall when they followed, they found 20% new nodules actually. So it seems like, yes, pregnancy is increasing the risk. Yes.
Yeah, thank you. So Dr. Monashis, should suppose there's a woman who has a pre-existing thyroid nodule and she gets pregnant, so should she have serial monitoring in pregnancy?
Hi, thank you, Dr. Maithili, and thanks to the organizer. In terms of any pre-existing nodule and who has entered into pregnancy, so we understand that some evaluation should have or would have been done before she entered into pregnancy. And it was a kind of, if it was a benign nodule, and for sure a lot of discussion with an endocrinologist would have happened. And with the current pregnancy, all that is required is possibly, with the skew that I'm taking from Dr. Samir as well as Dr. Harmandeep, that there is, based on the pathophysiology, a little bit of a growth, even if they're around 10% or so with the nodular size. Maybe a kind of a trimester specific, just a first trimester routine screening once again, and a second trimester. Nothing beyond the second trimester, because anyhow the indication of if any intervention is required is only at the second trimester. So there's no point of even intervening beyond the second trimester.
Yeah, I think very nice. So I think the evaluation again for a thyroid nodule also starts with the assessment of TSH. So Dr. Samir, after the assessment of TSH, how would you proceed with evaluation of a thyroid nodule?
Yeah, in fact, doing a TSH is a good investigation, seems to be in non-pregnant persons, but the issue of HCG causing suppressed TSH coming into play creates a little bit of confusion, because we usually find suppressed TSH, especially during first 3 to 4 months of antenatal period. But in case you find a non-suppressed TSH, I think we must do an ultrasound for a thyroid nodule encountered in pregnancy. And maybe after that, we can go on to FNAC depending upon the ultrasound characteristics and the size of the nodule. But that's beyond 14 to 16 weeks if you are finding, or maybe earlier on if you find a raised TSH and a thyroid nodule, I think ultrasound has to be done, and then FNAC depending upon the size and the ultrasonography criteria of the nodule, whether it is suspicious for malignancy or not.
Yeah. So I think the suppressed nodule is, the suppressed TSH is unique in pregnancy. And as you said, that needs to be kept in mind.
Yeah.
And so once ultrasound confirms the nodule, so it may be anything from thyroids 1 to 5. So Dr. Harmandeep, how do you serially monitor this nodule in pregnancy? So it may be benign, it may be indeterminate, or it may be malignant. So how would you repeat ultrasound? Should it be periodically repeated?
Yes. So if we have found ultrasound, we go by ultrasound characteristic first, like whether it is we should go ahead with FNAC or not, and then we will include FNAC data as well. So if, as Dr. Monashish has said, like after all the investigations, if we have found like we are dealing with a benign nodule, then probably our, as per society guidelines also, we know that probably we don't need to investigate it further. We are dealing with a benign nodule. But problem occurs when we are dealing with the suspicious nodules, or where FNAC also comes as of unknown significance kind of thing, and the suspicious ones. These are two groups where we would like to see. And as we know, like if any intervention has to happen, that will happen in second trimester, and that gives good gap also between first and second trimester. So by mid gestation, like around 24 to 26 weeks, you can go for second evaluation. You can go for next ultrasound, and if you find like there are it is increasing in size, or all the criteria which we follow for surgery. So second evaluation should be done around 24 weeks, because if something has to be done, that has to happen at that moment only. Yes. So second evaluation generally we consider in second trimester.
Thank you. So Dr. Monashish, how will you plan FNA in a pregnant lady with a thyroid nodule diagnosed on ultrasound? So are there any considerations? And if you want to do FNA, what is the timing?
Yeah. So that's a kind of a retro answer, because if the best timing for any surgery is the second trimester, the fundamental thing is, if any nodule that is picked up even at the kind of a later part of the second trimester, frankly speaking, the FNA can be even deferred to the postpartum. So therefore, the timing for an FNA, if at all it is to be done, and we are talking about the garden variety where it is either an indeterminate or something like the ultrasound, which is not truly very over to tell us that this is a malignancy or no nodal lymphadenopathy. So the best time would be kind of a second trimester, early second trimester. Towards the late second trimester, there is no point, because it does not influence our decision making. The bottom line out here is that, again, from a criteria perspective, despite the fact that there is a slight increase in the volume of the thyroid nodule during pregnancy, most guidelines always suggest that the criteria for FNAC is the same as that of a non-pregnant adults. And from my practice, typically we have been using the TIRADS category only.
Yeah, Dr. Monashish, if the TSH is suppressed, what would you do about the FNA testing?
Typically not. I would generally, because the chance, say the whole point of an FNA is to find out the cancer if that needs an intervention during pregnancy. If that is the solitary basis, with a suppressed TSH, if at all, from a kind of a pregnancy trimester range specific, if it is suppressed, and by kind of a fair estimate, if it is like a functional nodule, the risk of cancer is pretty less. Okay. So therefore, the indication of an FNAC is also not very high if the TSS is low.
Yeah, thank you. Thank you. So I think, suppose the nodule is malignant, Dr. Samir, what is the approach and what are your take-home messages? Dr. Samir.
I think once you have this malignancy coming up, so it creates a lot of apprehension in mind of the pregnant patient, female. So, so we need to, in fact, have a sort of a multidisciplinary approach in this setting. That's, I think, is of paramount importance. But yes, I think once you have done a FNAC, it's clear cut showing carcinoma. So there can be two things which can come up on FNAC. Like it can be a differentiated thyroid carcinoma, or it can be like anaplastic or undifferentiated, or like MTC medullary thyroid carcinoma. So I think the approach is different for each of these. So if you have a differentiated thyroid carcinoma, and we would like to have a weight approach for the patient, usually the surgery has shown to be associated with risks, which can be intraoperative risks also. So usual approach is to hold on till the time of delivery, and then maybe we can take a call. Okay. But in case the nodule which is malignant is showing some aggressive behavior, which can be significant increase in growth, or it is showing some compressive symptoms onto trachea or by nearby vessels, or if there are significant metastatic local lymph nodes in the neck, I think we must go for surgery as per the ATA latest guidelines. And that's, as Dr. Monashish was saying, second trimester seems to be the favorable period. I don't think we wait for anaplastic or MTCs or poorly differentiated carcinomas. We usually go for surgeries in these cases. So that is what I understand from the guidelines.
Yeah, thank you. So to continue with what Dr. Samir just told us, Dr. Harman, can you please sum up the indications of surgery and what is the ideal time for surgery if it has to be performed during pregnancy?
Yes. So if surgery has to happen, like what are the indications? If I say, so majorly thyroid malignancies, we know they have a very good prognosis, and generally we don't prefer surgery during pregnancy. They have a good prognosis in pregnancy as well. So there are some chances, like if it is locally invasive, if it has extrathyroidal extension, if there are lymph node metastasis, if disease is severe, it is aggressive tumor, it is increasing in size. So that is the situation, like, yes, you will have to go ahead with surgery, and second trimester is the best trimester. We have good evidence for that. So it is mid gestation or second trimester where we will plan surgery.
Okay. So is there any concern of delaying surgery, and do you think that affects the tumor prognosis when you do surgery postpartum, postpone it? Are there any concerns of increase in the recurrence? Or
yes,
I think this is an uncertain area.
Yeah, this is an uncertain area. We have a lot of data, like conflicting results. Some studies, they are saying there is little bit increased risk of persistent disease or increased recurrence, but again there is data which is showing like there is no change in prognosis. And one thing everybody is coming on to is what is the effect on overall survival as such. So that is same, actually, that is not different in both the cases. And secondly, there was a recent study from Japan also, where the CAs which were less than 1 centimeter, they followed 50 patients actually. So that was a good study. Others were retrospective or something. So here they have not seen any increase in size, or it was a mild increase. And postpartum also, they have kept them in active surveillance only. And till the study was published, they were hoping like they can go ahead with second pregnancy as well. So there is hope. Mostly we feel like it has a good prognosis and does not affect survival. Yes.
Thank you. So finally, this is the last question, Dr. Monashish. If FNA shows indeterminate cytology, is there a role for molecular markers in pregnancy?
Thank you, Dr. Medley. I mean, this question about a molecular, although however it sounds very lucrative, and at least from my personal context, I have not used among my patients any confirmation by mutational analysis or a gene analysis. And since we are talking about pregnancy and thyroid nodule, the best solution related to it, I'm actually proceeding back with this answer from Dr. Harmandeep when she stated about the prognosis. Well, because the prognosis is not different when we're talking about from a differentiated thyroid cancer and when they are being operated during pregnancy, vis-a-vis when it is operated postpartum, if the prognosis overall is not very different. So what are we looking from a kind of a molecular markers is to find out if there is a chance of that malignancy which is being missed out by the indeterminate cytology. So number one, there is not much of a role out there. Number two, it has not been validated. And the third is when Dr. Samir and Dr. Harmandeep were talking about the nodular increase in the volume. I think the confounding theoretical factor also is the HCG and the estradiol will also do around with this kind of a nodular gene expression, and therefore perhaps it is not very validated.
Okay.
Not of much role.
So we only go by ultrasound.
The ultrasound features, if supposedly ultrasound was, so ultrasound is suspicious, did an FNAC. The FNAC is indeterminate. All that is required is just if it was diagnosed during the first trimester, just do a repeat ultrasound in second trimester, something different, repeat an FNAC. As I said that I'm not sure if anyone is using the molecular markers from the routine test. Thank you.
Thank you. Well, I really sincerely appreciate all our three distinguished panelists for the very nice answers they have given us. And may I now request our chair, Professor Shubhankar Chaudhary and Professor Kalpana Dash to have give us their comments and questions, if any.
Thank you, Dr. Maithili. That was very well conducted and with all those able support from our speakers. I think basically we do understand that there is an increase in thyroid volume in pregnancy. There are also some prospective studies through pregnancy from first to third trimester to show that new nodule formation also does happen. However, possibly new malignant lesions do not develop. I mean, could theoretically develop, but do not come to attention possibly during pregnancy. And I think we all now understand the importance of ultrasound, the thyroid scoring, and to decide what to do subsequently. I think it's been dealt with very competently. Thank you all the three, Samir, Monashish, and Harmandeep. And we are now awaiting a very exciting quiz. So, which will be taken forward by Dr. Alpesh Goyal, who is Assistant Professor in Endocrinology at the AIIMS New Delhi. He has a number of awards to his name, including the ESI A.V. Gandhi Award in 2018, the MMS Ahuja Award as Best Team Student from All Indian Institute. Also, he was the winner of ESI TISA in 2017 and so on. And he's already got several publications in index journals. So over to you, Alpesh.
Thank you so much, sir. And
and is there a prize for the quiz winners?
So that
yes, so we'll be sending them later on. So once we have the information, we'll be sending it out.
And you have a foolproof method of identifying.
Yes, so if somebody is on the audience link there.
Great, good.
No cheating.
Yeah.
Okay. Thank you, sir. Ma'am, the slides are visible.
Yes, Alpesh, we can see your slides. You can start moving.
Yeah.
Yes.
Okay. Okay. Thank you so much for the invitation, and it's an absolute pleasure to be here. And I'll begin the quiz. Before I begin the quiz, it's a simple case-based quiz of 5 questions, and you have to answer the questions in Ask a Question box, and you have to answer all the questions together and then send it to us. So after I finish the quiz, I'll give you around 30 seconds time. And then in that time, you can send all the answers. And after that, I'll discuss the answers as well.
Yeah, so Alpesh, just again, repeating this instruction for all the delegates, please type in your answers as 1A, 1B, whatever the option is, and all the questions will be dealt with together. So type in your answers, put them in the Ask the Question box, and then we'll discuss it later. Thank you.
Okay. So I'll now begin with the quiz question number 1. This case is about a 32-year-old female who has presented to us with symptoms of thyrotoxicosis for last 6 months. On examination, she doesn't have any goiter or any neck tenderness. And we asked for a thyroid function test. Free T4 is elevated at 5.6 nanograms per dl, the upper limit being 1.7 nanograms per dl. Free T3 is also elevated at 5.8 picograms per ml, and TSH is suppressed to less than lower detection limit of the assay. She has tested negative for anti-TPO and anti-thyroglobulin antibodies, and her thyroglobulin levels are also below the lower detection limit of the assay. And the technetium 99 thyroid scan has been done, and which has been shown in the right panel. So with these clinical details, the question is, what is the most likely diagnosis in this patient? A, Graves' disease, B, struma overi, C, thyrotoxicosis factitia, and D, subacute thyroiditis. So you have to mark the answer. It's A, B, C, or D, and then we'll move to the next question in another 5 seconds time. Okay, moving to second question. So this question is about a 28-year-old female who is pregnant, primi gravida, and she has presented to you at 12 weeks period of gestation. This is a singleton pregnancy, and she has presented for evaluation of abnormal thyroid function test. She doesn't have any goiter. She doesn't have features of thyroid orbitopathy or thyroidomopathy. Her past history and family history are unremarkable. And when you performed the thyroid function test, you found that T4 was elevated at 18.4 micrograms per dl, the non-pregnant range being 5.1 to 12.1 for this particular assay. Free T4 was 2.4 nanograms per dl, with the normal reference range being 0.93 to 1.7, and TSH was suppressed at 0.05 micro international units per ml. So based on this clinical and biochemical picture, the question is that which of the following options would be most appropriate in this patient? So option A is to start propyl thyrosil followed by shift to carbimazole at 16 weeks period of gestation. Option D is advise termination of pregnancy. Option C is to advise a technetium 99 thyroid scan. And option D is to advise measurement for TSH receptor antibody. Okay, moving on to the next question. This is question 3, and this is about a 50-year-old female who had a last childbirth 27 years back, and this delivery was complicated by postpartum hemorrhage. She had lactational failure during that delivery, following that delivery, and had oligomenorrhea for initial few years, and then had secondary amenorrhea for last 18 years. She presented to neurology outpatient for evaluation of proximal myopathy. And on examination, her blood pressure was 98 by 60 millimeters of mercury. And when a metabolic workup was done, it was found that T4 was profoundly low at 0.42 micrograms per dl, and TSH was 2.24 milli international units per liter. Cortisol was 4.8 micrograms per dl. ACTH was 4.6 picograms per ml. And prolactin was also 0.53 nanograms per ml, which is also very low. So these are the clinical pictures of the patient. And the question based on this information is that, which of the following would be the most appropriate in this patient? Option A is to start levothyroxine alone. Option D is to start levothyroxine immediately and then add prednisolone after 3 days of thyroxine intake. Option C is to start prednisolone immediately and add levothyroxine after 3 days. And option D is to start prednisolone alone. Okay, moving on to question number 4. So this is about a 15-year-old female who has history of palpitations since early childhood. She has had normal academic performance. On examination, she has blood pressure of 124/58 millimeters of mercury and pulse rate of 108 per minute, which is regular. ECG shows sinus tachycardia. She doesn't have any goiter. And when we ask for a thyroid function test, we find that free T3 was elevated at 5.9 picograms per ml, and free T4 was also elevated at 2.8 nanograms per dl. TSH was 1.56 milli-international units per liter. So based on this clinical and biochemical information, the question is, which of the following would be appropriate in this patient? So first option is to measure sex hormone binding globulin and TSH alpha subunit levels. Option B is to do a screening thyroid function test for family members or first degree relatives. Option C is to obtain pituitary hormone profile and MR of cellular region. And option D is all of the above options. Okay, now moving on to the last question, question number 5. So this question is about a 52-year-old female who has been admitted in cardiac care unit for management of pulmonary thromboembolism, and you have received a call for abnormal thyroid function test. Her free T3 levels were 7.16 picograms per ml. Free T4 levels were 4.6 nanograms per dl. TSH was 2.59 milli-international units per liter. And triglycerides were 274 milligrams per dl. She is not symptomatic for any thyroid dysfunction. She doesn't have any goiter, tremors, or any features suggestive of pituitary mass effects. So based on this clinical and biochemical information, which of the following would be most appropriate to perform in this patient? You measure sex hormone binding globulin and TSH alpha subunit levels. Option B is to suspect a heparin interference and repeat thyroid function test after discontinuation of heparin. Option C is to obtain a technetium-99 thyroid scan. And option D is to measure TSH and T4 after precipitation with polyethylene glycol 6000, that is PEG 6000. So this is the end of the quiz. So we have had 5 questions, and you can type in the answers and send them to us. So I'll wait for another 30 seconds and then start with the discussion of answers.
In the meantime, I hope we have our earlier speakers, faculty members also with us. Dr. Unnikrishnan, Professor Jabbar. So because we have got a couple of questions from the audience.
So I cannot see both of them here right now, but maybe you and Kalpana can take those.
Yeah, fair enough. So this is a question, the person is not identified for the first question. In women with Graves' disease planning a pregnancy, should they be switched to PTU? My take is you have got to discuss. A PTU is not a good choice straight away, because PTU essentially, the usage, long-term usage of PTU is limited by the risk of liver damage, hepatitis, drug-induced hepatitis. So I must also say in the same breath that this is quite uncommon, but it does happen. So it is best that we discuss the possibility of a definitive treatment, maybe with radioactive iodine, maybe even with surgery. And then most likely this lady will become hypothyroid. And then make her euthyroid on thyroxine, and then only ask her to plan pregnancy and say that the entire process can take at least about 6 months or so. We have in the past, in the earlier part of my career, I'm sure for Professor Dr. Kalpana Das's career also, we have had several pregnancies seen through very successfully, safely on carbimazole itself, maintaining minimum doses of carbimazole. But in these days, even if we do that, it has to be properly documented that the couple is aware of the potential risks. So that would be my answer. We may go on to the quiz questions, and then Dr. Dash can take the other question with the woman with borderline high TSH, TPO antibody negative, prolactin 45. Dr. Prerna wants an answer. So it's Alpesh.
Okay, thank you, sir. So moving on to the answers. So first question. So this question was about a 32-year-old female, and we can see that she has presented with symptoms of thyrotoxicosis as a biochemical picture suggestive of thyrotoxicosis. And we can see that free T4 is elevated to a greater extent as compared to free T3. And technetium scan clearly shows that there is decreased uptake or no uptake in the region of thyroid bed, and salivary glands have increased uptake, which suggests a thyrotoxicosis with reduced uptake in thyroid bed region.
Alpesh, can you quickly tell us about this ratio of T4, T3 or T3 to T4 ratio?
Yeah, yes, sir. So a T3 to T4 ratio is often used to differentiate conditions such as hyperthyroidism from thyroiditis, or if you are suspecting exogenous thyrotoxicosis, because in patients with hyperthyroidism, you often get T3 as the first and most consistent abnormality, because there is upregulation of deiodinases within the thyroid gland, and also there is a concept called as iodine economy, where the hyperfunctional thyroid gland tries to preserve iodine and make more T3 as compared to T4. So in this patient specifically, where you are suspecting a cause for thyrotoxicosis and thyroglobulin levels are undetectable in face of negative anti-thyroglobulin antibodies, that means there is interference with anti-thyroglobulin antibodies is unlikely, and you have an absent thyroid gland uptake, the most likely diagnosis is going to be that of thyrotoxicosis factitia. Because in subacute thyroiditis, although you can get a similar scan picture and similar thyroid function picture, thyroglobulin will be elevated. So that's the answer for this question. And we know that thyrotoxicosis factitia, it's an important but rare cause of thyrotoxicosis, more commonly seen in young and middle-aged women, and who often have some psychological abnormalities. And at times it is very difficult to detect this condition, because patient actually may vehemently deny the use of thyroxine medication, and at times the doctors have to don the cap of a detective to detect this condition. And this is about thyrotoxicosis factitia. Sir, you want to put some comments on this, because this is a case that you
since you put up this paper that we had published some time back, I must tell you that we had great difficulty in publication of this paper, because we were asked from foreign editors, how ethical is it? How did you actually we had done? Because the patient herself would not own up to taking loads of thyroid tablets. So what we did was we got her admitted, and then we made her go for a scan, and then we went and rifled, looked inside her cupboard and took out her bag, and then got those small packets which had white tablets in it. And then we also sent that for assay in our lab. So this was very difficult. This was actually not ethical. So they raised all sorts of questions. So we had great difficulty in publication. Anyway, thank you. So let's go on to the next one.
Thank you, sir. This next question is about tackling women with thyrotoxicosis during pregnancy. So this woman had presented with a biochemical picture of thyrotoxicosis, and this is in first trimester, around 12 weeks period of gestation. As we can see, her T4 is elevated. During pregnancy, you can use total T4, but you have to correct for the total T4 by using a formula where from 7 week onwards you increase by 5%. So at 12 weeks you can increase the total T4 by 25%. So at 12 weeks you multiply 1.25 to the upper limit of normal, and clearly even if we multiply by 1.25, T4 is grossly elevated, free T4 is also elevated, and TSH is suppressed, which confirms the biochemical diagnosis of thyrotoxicosis. Although she doesn't have features suggestive of Graves' disease in form of goiter, orbitopathy, or dermopathy, she could still have Graves' disease, however. So the question that was asked was what is the correct option in this patient? Now, during this time of pregnancy, gestational thyrotoxicosis is also very common, and this is caused by increased SCG levels, which have thyrotropic effect and which go on to stimulate thyroid gland to produce excess T3, T4, and cause suppression of TSH. And because management of Graves' disease and gestational thyrotoxicosis is entirely different, it is advisable that these two conditions be differentiated. If there are clinical markers such as goiter, orbitopathy, or dermopathy, that's fine. Otherwise, it is advisable that you measure TSH receptor antibody. So the correct answer would be option D, to measure TRAB levels. And this is just a figure to show that as SCG levels go up during first trimester, they peak during 9 to 12 weeks of gestation, there is fall in TSH, and you can have elevated free T4 levels as well. So moving on to the question number 3, I think this was very clear from the case description that this was a patient with Sheehan syndrome, had features of multiple pituitary hormone deficiency, and she actually had, we had published this case, she had actually presented to neurology outpatient and was admitted in neurology ward. When we had a look at this patient, had all clinical features of myxedema, and although it is very uncommon to encounter pseudo-hypertrophy of calves in patients with secondary hypothyroidism, we did find this finding, and she also had pericardial effusion. And here you can see in this clinical picture that she has wrinkles around the eyes and around the angle of mouth. She has coarsening of facial features, and this is pseudo-hypertrophy of calves. And in such a patient who has multiple pituitary hormone deficiency, it is always advisable that you start glucocorticoid first and then add levothyroxine, so as to avoid increase in metabolic clearance of cortisol and prevent any adrenal crisis. So this question was about how to manage thyroid hormone replacement in patients with multiple pituitary hormone deficiency, and it is always advisable to start with prednisolone and then add thyroxine at a later date in order to prevent any adrenal crisis. So question number 4, and this question was about a young child who had presented with history of chronic palpitations, had sinus tachycardia, and you can see that free T3 and free T4 levels were elevated, but TSH was normal. So you would expect that in case of T3 and T4 elevation, there should be suppression of TSH in patients with primary hyperthyroidism or primary thyrotoxicosis, but this is an atypical thyroid function test, and this picture could be seen in patients with thyroid hormone resistance, TSH secretion, who have several biomarkers or several tests that are that could be indicated. So, for example, measurement of sex hormone binding globulin as a biomarker for thyroid action, because this will be elevated in patients with TSH adenoma, but in thyroid hormone insensitivity, these levels will be normal. Screening thyroid function tests for family members could be helpful in patients with thyroid hormone resistance, as it is a condition which is genetically inherited. Obtaining pituitary hormone profile and MRSLA would be indicated to rule out a TSH adenoma in this patient. So,
Alpesh, quick one. Yes, so TSH, alpha subunit of TSH, yes, we have not yet been able to get it done anywhere. So how do you solve that at AIIMS Delhi?
The TSH alpha subunit, this is you can do glycoprotein alpha subunit assays, and although we don't do it in-house, but there are some commercial laboratories which are doing it, sir.
Which one? Because we have tried on a few occasions, we couldn't get it done. So maybe you can share later on.
Okay, sir. Sure.
Okay. Yeah. Thanks.
Okay. So this is the profile that patient had. TSH secreting adenoma and thyroid hormone resistance were the two differential diagnoses, and these were the options that were available. All of these could be indicated on a case-to-case basis in a patient. Question number 5 was about a 52-year-old female admitted to a cardiac care unit, and she had elevated free T3 and free T4, but her TSH levels were absolutely normal. She didn't have any thyroid dysfunction, and this is a classical case of an hormone assay interference caused by heparin, and it is advisable that you measure total T4 and total T3, which would be normal, or you repeat TFT after discontinuation. So what happens is that heparin, it increases the circulating lipoprotein lipase and heparin hepatic lipase, and this causes increase in plasma lipolytic activity, increase in plasma free fatty acid levels. And while this happens in vivo, it also continues in vitro. So if the sample processing time is delayed or the temperature is optimal for these enzymes to act, this will lead to increase in plasma free fatty acids, and this could lead to displacement of T4 from the binding proteins and false or artificial elevation in free T4 and free T3 levels. Our total T4 and total T3 levels will be normal. So it's always important that you interpret the lab picture only in the background of appropriate clinical context, because there could be so many immunoassay interferences that could be possible or could be existing in a given patient, and these are just examples which have been listed in the left panel. So thank you so much, and I had a great time preparing this quiz, and I hope you enjoyed it.
Thank you. And the other great lesson is, at least as an endocrinologist, we would by and large avoid advising for a thyroid function test or for most endocrine tests in a patient who is in CCU unless we feel that there is something that we can offer by way of treatment. Maybe for myxedema, coma, or whatever thyroid crisis, we would send off, but our treatment actually will start even before getting those results, because there can be so many mimickers, so many confounders to the result. So I think, Gagan, we are through our period. So does Dr. Kalpana Das have time to answer the questions? Or,
yes, we can take one more question, sir. So Dr. Kalpana can answer this one question that's in the chat.
Dr. Kalpana, please.
Yeah, which is the question?
So
maybe
there's a question from Dr. Prerna that a patient has a borderline high TSH, TPO negative, and a prolactin of 45. So how would you approach this case?
And thank you, Alpesh.
Yeah, please tell.
Thank you, sir.
Hello?
Yeah.
Yes,
Hi,
Dr. Kalpana, we can hear you. Please.
Yes, someone may stop sharing the screen.
Yes.
Yes.
What was the question, sir?
So there's a lady with high borderline elevated TSH, a prolactin of 45 and antibody negative. How to approach this patient?
This could be just simple autoimmune thyroid disease, subclinical hypothyroidism, and hyperprolactinemia could be because of the subclinical hypothyroidism. So I think we should go ahead with a free T4, and antibody is positive, you told me?
No, antibody is negative.
Antibody is negative, it's okay. So we can just go for a free T4 and look for what is the function, and we can repeat the TSH maybe after 6 weeks, because the antibody is positive. And maybe in some cases, if you can do a lipid profile, if the lipid profile is in a higher side and if subtle symptoms are there, we can start with a small dose of thyroxine replacement. For some time, maybe we can work out again the thyroid function and prolactin after 6 weeks or maybe after 3 months. This is how I will approach.
Yeah, we need to ask if other things also, look at the subject, why this prolactin is mildly elevated, drugs and all that. Yeah, thank you.
Those things has to be evaluated definitely.
Yeah.
Yeah. Thank you, Dr. Kalpana, and thank you,
Yeah.
Dr. Shubhankar. It was a wonderful session. Thank you, Dr. Alpesh. I was completely engaged in your quiz. The cases were very interesting. So moving on to the next session, which is on menopause. I would invite the session coordinators for the next session, Dr. Arundhati Dasgupta and Dr. Lakshi Deka. So Dr. Arundhati, I have the good fortune of working with her in past, a very lively, energetic person. Now she runs Rudraksh Super Speciality Care Center at Siliguri. She's director and senior consultant endocrinologist there. She has many achievements and awards in her back. So A.V. Gandhi Award for Best Thesis in 2012, Diabetes Awareness Initiative Award in 2018, course coordinator for PHFI and several other training programs, and presentations in various national and international platforms, along with many international publications. So Dr. Arundhati, the next session coordinator is Dr. Nilakshi. Dr. Nilakshi is a consultant endocrinologist at Apollo Hospitals, Guwahati. She has received the award or title of Best Graduate of Assam Medical College and Hospital in 2002. A.V. Gandhi Award for Best Thesis Topic in Endocrinology 2013, several publications, and invited speaker at various national conferences. So over to you, Dr. Arundhati and Dr. Nilakshi.
Thank you so much, Dr. Veena. It's wonderful to be a part of this, program, and wonderful to be a part of this session, menopause. Remember, say about 3 decades back or 4 decades back, when you generally would think of the term menopause, you would generally, picturize a lady, an old lady who's kind of lived her life, the prime of her life has gone, and she must accept that, certain things are not there, they have gone. Cut that to today, where we are talking of young, dynamic women walking into their 50s with grace, with elan, accepting it just as another phase of life, which is just as beautiful as any other, and probably needs a little bit of tuning in. Now, it is in this little bit of tuning in that sometimes we as doctors need to hold their hands, be it in terms of, hormone replacement therapy or maybe a little bit of counseling. So we will be discussing all of that and much more in this session today. And I would ask my co-coordinator, Dr. Nilakshi, to please introduce the chairpersons for the session.
A very good evening, everyone. So our first chairperson for today's session in menopause is Professor Dr. Sushil Jindal, sir. He's MD in Medicine, DM Endocrinology. He's the Professor of Medicine, People's College of Medical Sciences, Bhopal. He has a lot of achievements and awards. He got his DM degree in 1986 from PGI Chandigarh. He has written various chapters in RSSDI textbook of diabetes. He has 25 publications in peer-reviewed international journals, editor of the Diabetes Patient Education magazine, Madhumeh Vani, and he was also the organizing secretary of ESICON 2013 in Bhopal. The second chairperson in this session is Dr. Deena Shestra. She is MBBS, MD Endocrinology, Senior Consultant Endocrinologist at Norvik International Hospital, Kathmandu, Nepal. She was the president, CEPHES. She is in the editorial board of JCEM. Now she has various national and international publications. She was the past president of DEAN. She is the founder of Diabetes Rehabilitation and Research Center. So I would like to invite our chairpersons to this session.
Thank you.
Thank you so much.
It's my pleasure to be part of this wonderful program, and I must thank Dr. Gagan Priya and her team for inviting me here. As said, we are going to discuss about menopause, and as we know that with increasing longevity, we'll be seeing more and more postmenopausal women in our country. And estimated is that there are almost 1/3 of our adult population of females live with the postmenopausal phase in India. And we also know that menopause is not only a declaration of end of reproductive life, but it also is a sort of entering into accelerated phase of aging also. And it's also associated with certain implication, increased risk for cardiovascular disease, osteoporosis, and we also know that vasomotor symptoms may be very disturbing. So with these all possible comorbidities and the challenges, how can we help our women with postmenopausal years so that they can be very productive part of the society and they can live a normal life? So for this, I'll invite my co-chairperson, Deena Shrestha, to introduce the first speaker. Over to Deena.
Thank you so much, Dr. Sushil, and it's really nice to be a part of this program. So Dr. Radhika V. Kumar, MRCP Endocrinology, CCT UK, Postgraduate Certificate of Healthcare Management. She's a senior consultant physician and endocrinologist working in Manipal Hospital, Bangalore. She was awarded the Young Investigators Award in 2010 in Scotland and the Best Poster and Oral Presentation in Telemedicine when she was in London in 2010. She's the former consultant physician of Aberdeen Royal Infirmary in the UK and IIM Kozhikode Alumni Healthcare Management and Analytics. I think it's going to be a pleasure to listen to her, Dr. Radhika Kumar.
Thank you, Dr. Deena. I wonder, can I start sharing my screen? And if the host would allow me to start sharing the screen.
Yes, ma'am, you can say, ma'am.
Can you see my screen?
Yes, ma'am.
Thank you. Thank you, Dr. Gagan and Women Endocrine Indian Group, for this kind invitation. I'm really quite excited being part of this scientific session for today and tomorrow. And just with a nice introduction by Dr. Arundhati and Professor Sushil Jindal about the menopause, I would like to just setting the tone for the discussion for the rest of the couple of hours of discussion on menopause. So the task which has been given to me is to throw some light into the complementary therapies in menopause, which has been practiced in India and globally. Just to start with the definition of menopause, the WHO definition has been it is defined as a permanent cessation of menstruation resulting from the loss of ovarian follicular activity, which can occur either naturally, surgically, or as a result of medical intervention, and is confirmed only after 12 consecutive months of amenorrhea.
Radhika, can you make it full screen?
Yes, and the slides are not moving, I believe.
Oh, is it not?
Yeah.
I believe you'll have to stop screen sharing and restart again once.
Okay, yeah. For me, it is appearing as full screen.
You can start screen share again once and then let's proceed.
Yeah. Are you able to see my screen?
Yes, we can see it.
But I think it's not on slideshow.
Is it in full screen now, slideshow?
No, that slideshow is not working. Otherwise, your slides were moving down.
Oh, right, okay.
Or else, Dr. Radhika, you could email the slide to me and maybe we can move to the next speaker because then we'll already be running out of time.
Sure, okay,
and maybe we can take your call right after the next speaker, if the chair.
Okay, I'll email the slides.
Okay, so we move on to the next topic, which is regarding menopause and sexuality. Again, a very interesting topic. Most women will think that menopause is end of the sexual life. And for this, we have Dr. Ekta Kapoor. Can I have the CV slide of Dr. Ekta Kapoor? Yeah. So she's American board certified endocrinologist and menopause specialist, associate professor of medicine at Mayo Clinic and Rochester, USA, and also assistant director, Mayo Clinic Center for Women Health. Renowned national expert and leader in menopause, leads multiple large studies related to women health. Project lead for clinical care at Mayo Clinic SCORE. I don't know what is the full form of SCORE. PI and RCT investigating effect of estrogen on CVD risk parameters in women undergoing perimenopausal bilateral oophorectomy. Also PI for Mayo Clinic Registry for Midlife Women HERA and Mayo Clinic Registry for Women with Menopausal Oophorectomy. MCORE, speaker at national and international conferences, extensively published on subject of menopause and hormone therapy, and lead editor of Practice Pearl Task Force from North American Menopause Society. So I'll invite Dr. Ekta Kapoor for her deliberations. I hope this time screen works well.
Yeah, we have a recording for her, so can we start that?
Yes, yes.
Mintu, the voice is not playing up.
Yes, I think it's not.
Please check. The volume is not there.
Okay, ma'am. One.
I think like menopause, this has also gone on a pause, this session.
Ma'am, can you hear the voice now?
No.
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 You can't hear the voice?
No.
No. No.
Okay, 1 second.
For this presentation on menopause and female sexual function.
Ma'am, can you hear now the voice?
Yes, yes.
Yes, we can hear it. Please continue.
Hello everyone, I am Ekta Kapoor and I'm delighted to be joining all of you virtually for this presentation on menopause and female sexual function. So here are my disclosures. The objectives for the next 20 minutes for me will be to review the sexual function changes in women after menopause and then to discuss the principles of management of sexual dysfunction in women after menopause. So when it comes to sexual function assessment of women, I'm thinking you're all probably familiar with this model, the so-called biopsychosocial model, meaning that female sexual function is a complex issue and it has multiple determinants in all of these domains that are shown on the slide. So the biologic, psychologic, interpersonal, and sociocultural. Now, all of these come together and have a complex interplay and determine a woman's sexual function. As you can imagine, not each of these components contributes equally in any given patient, but all of them somehow influence a woman's sexual function. So when we say biologic component, we're really talking about neuroendocrine function, hormonal status, medical conditions, genetics, the medications that the patient is on. When we're talking about the psychological component, we're referring to things like mood disorders, anxiety, problems with self-image, etc. When we're referring to interpersonal component, we are really implying the relationship factor, because no matter how strong the hormonal status is and whether the mental health of the patient is good, if the relationship is not good, her sexual function will be compromised. And then the last but not the least component mentioned here is the socio-cultural one, meaning what are the woman's expectations regarding intimacy? What has she grown up hearing about intimacy? What kind of messaging has she received? And what are her personal beliefs and attitudes? So as you can imagine, those also very significantly impact a woman's sexual function. So now let's just try to tease apart how each of these components comes into play in women after menopause. So when it comes to the biology component, let's first talk about the consequences of estrogen deficiency, which is the hallmark of menopause, right? So vasomotor symptoms, hot flashes, night sweats, very common after menopause. About 3/4 of women will experience them at some point in that transition, and they can significantly impair quality of life. They can do it just by themselves, occurring during the day or night, but at the same time, they can impact health via other means. So they can disrupt the sleep for a woman, they can impact her cognition, and they can impact her mood. And all of this can have a domino effect on a woman's sexual function. So you can imagine a patient who's not sleeping well, is struggling with mood problems, is not going to have much of a desire for intimacy, right? The other thing to remember is that these neuronal pathways that control sleep, cognition, and mood, the neural control, the neurotransmitter control, these pathways are shared with those that control sexual function in women. So if one of them is deranged, it's likely that somehow sexual function also gets impacted because of the way these neuronal pathways are affected. Then not to forget the effect of vaginal dryness, which happens after menopause. And again, it's a direct consequence of lack of estrogen. So this results in pain with intercourse. The genital sensation gets impacted, which impacts the whole pleasure response, lubrication, and arousal. Then midlife women often tend to have joint pains, which could be outside the setting of arthritis or in the setting of arthritis. Rheumatologic conditions, the prevalence of conditions like rheumatoid arthritis, SLE, goes up in that phase of life. So these can impact the physical function of a woman, which can have a bearing on her intimate life. Then other medical problems, as we're getting older, the chances of many health conditions goes up, including hypertension, diabetes, and they could be impacting a woman's sexual function also. Lastly, there are several medications out there that can impact a woman's sexual function, and that therefore it's very important to pay attention to what her medication list looks like. The notorious ones in this category are antidepressants, the SSRIs and SNRIs, which can profoundly impact sexual function in a woman. Next issue is that of androgens, the main one being testosterone. So it has long been known that testosterone and other androgens have a permissive role in female sexual function. So how is that changing as a woman is getting older and she's getting past menopause? So as I'm showing you on this slide, female androgens DHEAS, DHEA, androstenedione, and testosterone are being made from adrenal glands and ovaries. The main female androgen is testosterone, which comes about 50-50 from adrenal glands and ovaries. So what's happening with menopause and what's happening with aging to these androgen levels? A very well conducted study long ago informed us in this regard. So what I'm trying to show you here is that when it comes to changes in androgen levels with aging and menopause, there isn't really a significant change in these hormone levels, all of them with menopause per se. But there is an age-related decline in all of them. So as a woman is getting older, these levels, as I'm showing on this slide, are getting lower, but there isn't a characteristic decrease with menopause per se, as happens with estrogen. So what then is the role of testosterone in female sexual function? Why do we worry about the fact, why should we worry about the fact that testosterone levels are going down in the aging woman? Well, it is an important reproductive hormone in women. It contributes to sexual differentiation of the genitalia and the brain. It contributes to development of secondary sexual characteristics and sexual maturation and maintenance of functional state of these organs in adulthood. And then it modulates sexual behavior as it relates to desire and arousal via both central and peripheral mechanisms. Now again, on this slide, I'm showing two important components of sexual function, desire and arousal, and how they are controlled by excitatory and inhibitory influences. And as you can see, testosterone has an excitatory effect on both desire and arousal. Coming now to the psychological factors that could be impacting a woman's sexual function after menopause. So midlife women tend to have a greater risk for depression and anxiety, and a lot of this has to do with declining estrogen levels. So as I was telling you earlier, vasomotor symptoms can cause depression in a woman in and of themselves if they are occurring very frequently and are very severe. But at the same time, just falling estrogen levels themselves outside the setting of vasomotor symptoms can have a negative impact on the mental well-being of a patient. So oftentimes patients who've had a long-standing history of depression, well controlled with therapy, once they become perimenopausal, postmenopausal, it can be a little difficult to control. It also happens that patients who do not have a previous history of a diagnosed depressive disorder as such, but may have had some premenstrual symptoms or a history of postpartum depression, and they have a new diagnosis of depression and anxiety around menopause. Happens all the time. Then this is also the age where women often experience high stress levels. We refer to them as the so-called sandwich generation, meaning on the one hand, you have children who are getting older and the stressors that come with teenage children in the house, and then aging parents. So taking care of both generations can be a significant burden on women at this age. At the same time, there are important physical changes happening in a woman's body that can negatively impact her body image and self-esteem. What are those? We know that midlife is associated with weight gain in women and unfortunately with abnormal body fat distribution. They gain what is called the belly fat, which is physically unattractive to a lot of patients. Then hirsutism, acne, hair loss, all of these to some degree can impact the self-image of women after menopause. Then interpersonal issues. This is often a vulnerable time in the life of a woman because of the physical changes that she's experiencing, the symptoms that she's experiencing that she unfortunately does not have much knowledge about. I mean, I practice in the United States and one would think that women here are very educated and they would know what menopause brings to the table and how it should be treated. But sadly, that's not the case. Most of the patients really do not receive much education. So in my home country, India, particularly in the rural parts of India, I can't even imagine patients knowing much about menopause. So this is time for a lot of confusion and they often feel like they're not supported, particularly not supported by their partners. So lack of that support from partners can impact their intimate life. Then the socio-cultural component, what do I mean by that? So, there are norms and messaging that a patient receives. For example, if she has heard from her friends or family members that after menopause, intimate life is not supposed to be the way it was in her younger years, that's something you don't think about, etc. Just examples. But the messaging, what is she seeing, what has she heard growing up, can really impact how she views sexuality after menopause. So when it comes to evaluation of sexual dysfunction, the important point that I want to stress for postmenopausal women, it's a very common problem. And as I was telling you that even in the United States, where you would think that people should have good understanding about these things and should be open about these discussions, that's really not the case. So even in this country, it is underdiagnosed and undertreated. So patients often will not bring it up with you, even if they are seeing you for some related concerns like menopause symptoms. At the same time, it's not a trivial issue that if it's underdiagnosed, it's not like we can say that, okay, we don't really care about it. This is a trivial matter. We can move on. Not the case, because it leads to significant impairment and quality of life. So I think these issues have to be actively sought, proactively sought in a patient that you're seeing. So in our clinic, even patients who come in for menopause consultations, we have them fill out some questionnaires for sexual function assessment and proactively seek that history and offer management options. And as I have shown you in the previous slides, that when it comes to assessing a woman's sexual function, there is no replacement for a detailed history, because you want to be assessing all potential contributors to sexual dysfunction using the biopsychosocial model. Extremely important. So nothing can replace a detailed history taking. So then the question comes, what about laboratory testing? Should we be testing testosterone levels? I'm sure you hear this all the time in your practice also, that the patients may be asking you about checking testosterone because they have a low desire and they think that that might be playing into it, or they've had a testosterone level checked for some reason and they come to you with a low level and they want you to interpret it and want you to tell them whether that could be contributing to their sexual problems. Now again, I don't imagine this situation occurring very frequently in India, but this is a scenario that I do see here where patients will come in with these lab values. What does the testosterone level really tell you? Now, some very well conducted studies have informed us that a so-called relative testosterone deficiency, meaning a woman who's had bilateral oophorectomy, right? So we know 50% of her testosterone is probably gone because that was coming from the ovaries. Or as in the aging woman, as I showed you, the testosterone level does go down. So there is fairly strong evidence to suggest that when the testosterone levels go down, women can develop what they call the hypoactive sexual desire disorder, meaning their desire for intimacy goes down, that's otherwise unexplained. But then again, it's very important to realize and to understand that there is a lack of a consistent relationship between testosterone levels and female sexual function. So it's not like you have a certain threshold that you can define and say that if a woman's testosterone level is below this threshold, she's going to have sexual dysfunction, and the level is over it, then she's good. That's a deduction we just can't make. And part of the reasoning for that is the biopsychosocial model that I showed you previously, that female sexual function is complex and there is not one single issue that can be considered a significant contributor. The classic example that I give in this situation is PCOS. These women have high testosterone levels, but they often have the worst sexual dysfunction that you will encounter because of significant body image related concerns, depression and anxiety in this patient population. So a testosterone level really is not informative from that standpoint. The other important thing to understand is that sensitive assays, which are chromatography and spectrometry based, are not routinely available. The RIA based assays are not as accurate for measuring testosterone levels because they are very low in women, right? The levels are 1/10 of those of men. So in that very low range, it's very hard to differentiate low from very low. So the testosterone level that you're looking at, it's very hard to interpret it depending upon what assay has been used. So A, the lab itself is not reliable. B, we don't know what impact that laboratory value, even if it is 100% reliable, excuse me, and it's indeed measuring what it's telling you that it's measuring, does it have a clinical correlate necessarily? No. The other thing is that blood hormone levels are not reflective of tissue levels. So what you're seeing in the blood doesn't necessarily tell you what is happening at the tissue levels. And as endocrinologists, we all recognize that very well. So the message on this slide is that do not measure testosterone levels to diagnose deficiency in women or sexual dysfunction for that matter. So if a patient comes in to you with a testosterone level, wanting you to interpret it, wanting you to act on it, these are the counseling points for that patient. So coming to the most important piece now, management. So as has become amply clear that in the menopausal woman, there can be multiple contributors to sexual dysfunction. So with that detailed history, you want to elicit and assess what are the potential factors in any given patient and address them. So menopause symptoms, whether it's with hormone therapy or non-hormonal strategies. Now, hormone therapy will not directly impact sexual function as such, but because it will take care of menopause symptoms, make sure the woman's mood is better and that she's sleeping better and her overall quality of life is better, that can secondarily positively impact her sexual function. Then needless to say, aggressive management of vaginal atrophy, the so-called genitourinary syndrome of menopause, because pain is a very, very important negative effect on sexual function. Aggressive management of anxiety and depression with both medications and cognitive behavioral therapy, sleep disturbance, whether it's managed with behavioral therapy, medications, hormone therapy, relationship issues, marital counseling, no matter what else we do, whether hormone therapy or otherwise, if the relationship itself is hurting, nothing is going to help, right? So I think addressing that very actively is extremely helpful, is extremely important. Then again, stress management, psychological distress management. And if the patient is on any medications that you think are impacting her sexual function, consider changing them, consider lowering the dose. Now, in the real world, that's not always possible, particularly with antidepressants, but then you choose your battles and see what can be changed from that standpoint. And then again, as I've said before, recognize that a given patient will likely have multiple contributors, so the management often is multifaceted. Psychotherapy, the so-called sex therapy in this context, is very important also. And the most important component there is really resetting expectations. So my key sentence, my key statement to my patients is that the rules of the game are going to be different after menopause as a woman is getting older. So it's not like you don't play the game, but you just play it differently. So again, just making the patient aware, educating how their body is changing. So when I'm counseling patients, I actually sit down with them with that slide on the biopsychosocial model and tell them what all is changing that is negatively impacting their sexual function and how we should tackle it and how we can help the matters, but we certainly cannot expect for things to be the way they used to be when the patient was younger. So just resetting realistic expectations. Encouraging frank and open communication between partners, very important. There are very well conducted studies that have shown that patients who are just talking about their intimate life tend to have a better sexual relationship. And then, with sex therapy also, greater chances of success if other contributors to sexual dysfunction are managed first or concurrently. For example, a patient who's not sleeping or has bad vasomotor symptoms, if you only provide her sex therapy and not take care of those symptoms, she's not likely to be helped. You likely will not see improvement. So again, assessing all factors and addressing them concurrently is very important. I will just finish up in the last few minutes with what about testosterone, right? We talked about the permissive role of testosterone in female sexual function and how when it goes down with aging, that can negatively impact sexual function. So should we be considering testosterone for these patients, postmenopausal patients? So the global consensus position statement on the use of testosterone therapy for women came out for the first time in 2019. And this was simultaneously published in 4 important journals and endorsed by 12 international societies. So it was a landmark moment because for the first time, the medical community heard about what the recommendations from these societies are for testosterone use. So this consensus statement was basically based on a meta-analysis and systematic review, which brought out that testosterone use improves sexual function across multiple domains in postmenopausal women with hypoactive sexual desire disorder. So the expert panel said that the only evidence-based indication for the use of testosterone in women is for treatment of postmenopausal women who have hypoactive sexual desire disorder after formal biopsychosocial assessment. So what does that mean? That means that your patient postmenopausal is sitting in front of you and you have assessed for all potential contributors and those have been addressed first, and then there is nothing else to fix, so to speak, which as you can imagine really doesn't happen in the real world. But if there's nothing major that's jumping out at you or the other issues have been addressed, then testosterone use can be considered. The trouble is that despite demonstrable efficacy, testosterone products are not approved by national regulatory authorities, exception being in Australia, and that's because long-term safety data as it relates to cardiovascular disease and breast cancer is not. I put this slide here to tell you the different routes of testosterone use. It's really the transdermal route that we recommend because it bypasses the liver and it doesn't have any adverse effects on liver enzymes and lipid panel. The other routes are really not preferred. So again, careful discussion with the patient that this is not approved by the FDA, long-term safety data is not there, and we typically use testosterone creams and gels that are prescribed for men in 1/10 of the dose that you would use for a man. In general, we discourage use of compounded testosterone because there is no regulation of these products and there's lack of evidence for efficacy and safety. And there may be significant variability in the testosterone from batch to batch. As I told you previously, we don't check testosterone levels to diagnose sexual dysfunction or so-called testosterone deficiency. But if you've made the decision to give testosterone to a patient, you will want to get a baseline testosterone level then to make sure that it's not high to begin with. And then again, you will measure 3 to 6 weeks after starting it. Again, the goal being to make sure you're not giving the patient too much. You're trying to make sure her level is in the average premenopausal levels. So you're not checking levels to assess efficacy of treatment. That is assessed only on the basis of the clinical outcome. So is the patient feeling better? Is her sexual function getting better or not? So remember, the level will be checked once every 6 months, but not for assessment of the efficacy. So if no benefit is seen by the patient in 6 months, then we know that that's not where the problem is and the treatment should be stopped. So stated in summary, postmenopausal women commonly experience sexual dysfunction. The disorder is underdiagnosed and undertreated, but it significantly impacts quality of life. Therefore, it's important to assess for and treat. The etiology is multifactorial and multiple contributors typically coexist in any given patient. So it should be carefully assessed using the biopsychosocial construct that I've showed you. An assessment and treatment option should follow the biopsychosocial model. So treat the menopause symptoms, pay attention to psychological interventions, and assess the need for testosterone and sex therapy, and recognize that oftentimes you have to use a combination of these strategies. And with that, I thank you for your attention.
I believe Dr. Ekta will not be available for question answer session. Arundhati, can you?
She's not there, so we can move to the next talk.
Okay, so is Dr. Radhika ready with their talk and the slides?
Yes, it's there.
Okay,
Yes,
so Radhika, you can start your deliberation.
So the slides will be shared by Dr. Gagan.
Okay.
Thank you, Dr. Gagan. Right, thank you. So next slide, please. And the introduction part is more or less in terms of like introduction about menopause and the symptoms has already been spoken in detail by Dr. Ekta. Let's move on to the next slide. So just a quick mention about the epidemiology, like in Indian settings, the natural menopause occurs between the age of 45 and 55 years. The annual prevalence is believed to be 50 million cases approximately. And the Indian average is like anywhere between 44 years from a particular study, which has been published in 2005. But the age of onset is kind of different across different socio-economic groups. As early as at the age of 30 has been noticed, in particularly in rural areas, due to various reasons in terms of literacy, age of onset of menarche, parity, and menstrual cycles has been. The symptoms can be classified as short-term and long-term symptoms. Short-term, as you know, like vasomotor symptoms to be very dominant. In terms of long-term, it is declining cognitive function, musculoskeletal, cardiovascular, and metabolic problems, including osteoporosis. But principally in Indian women, the symptoms what has been perceived is mostly musculoskeletal, which is joint pain and muscle pains, as opposed to Western counterparts where the vasomotor symptoms has been most commonly reported. Next slide, please. In terms of the menopause management, like, we have seen the rise and fall of the hormone replacement therapy following the Women Health Initiative trial results in 2002. And we have been seeing a significant changes in the trends in the usage of the menopause management, because there has been persisting concerns about the risk of breast cancer and cardiovascular disease. With the release of the results, like, well-informed women has been kind of generally seeking alternative ways of complementary and alternative methods of therapy in terms of dealing with their various menopausal symptoms. The primary indication for the hormonal replacement therapy has been the vasomotor symptoms almost globally. Next slide, please. The CAM therapy the previous slide, the CAM therapy, a complementary and alternative medicine, the women believe this has to be a safer and more natural alternatives to traditional hormonal therapies. And the use of non-hormonal therapy is generally high, between 50 to 80%. A ovarian cancer screening cohort study it is in a UK collaborative trial, which has showed like more than 60 to 70% of the women with the ovarian cancer survivors has been found to use a complementary and alternative sort of medicine. But what has been seen is like there is a bit of uncertainty, and this uncertainty has been leading into inappropriate and ineffective therapies with respect to the dosing and the type of preparations. And this complementary therapies, alternative therapies are falling into two broad categories. They are the mind-boggling practices, like which includes hypnosis and cognitive behavioral therapy. The next one is the natural products, which is phytoestrogens, black cohosh, herbal preparations, And other alternative medicine approaches include traditional Chinese medicine, reflexology, acupuncture, and homeopathy, and so on. So, next slide, please. The complementary therapies mainly to mention about the botanicals, the preparation, the herbal preparations, what we come across normally. They do have these three activities, like the estrogenic activities, progesterogenic, and teratogenic activities. The estrogenic activities principally by the soy-related products and the red clover, which has been very widely used, and the progesterogenic activities is seen in red clover and wild yam preparations. And teratogenic is most commonly seen in black cohosh and also in licorice, which is very commonly used in Western population, and again in St. John's wort. Just particular mention about the phytoestrogens preparation. The phytoestrogens, they are mainly plant products, and they are high occurring as a diphenolic compounds that are similar in structure and function to the active component, the beta estradiol. In average, Asian women, they consume almost 20 to 80 milligram per day of isoflavones in comparison to Americans, which they consume 1 to 3 milligram per day. And there are many types, but major categories include the isoflavones, which are most commonly seen in soybeans and chickpeas. The other varieties are lignans, which are seen in whole grains, whole cereals, vegetable oil, and flaxseed, and coumastrins, which are seen in the sprouts, red clover, and sunflower seeds. The active ingredient which is seen in the isoflavones, which is the most abundant and active component, is the didzine and genistein. In various studies, the average dose of the effective dose of isoflavone which has been studied is between 60 to 90 milligram per day. Next slide, please. As a diet which is high in isoflavones, which is usually used by the Japanese and to a larger extent in Indian subcontinent, also found to have lower rates of menopausal vasomotor symptoms, particularly may be attributed to the higher consumption of the soy-related products. And where is this started from is like, the phytoestrogens in various randomized controlled trials has found to show like significant reduction in cardiovascular risk profile in terms of improving the lipid profile with the improvement in the angiogenesis and decreasing the platelet aggregation and thereby reducing the thrombotic events. And looking into the other aspects of like a tumorigenesis, it is found to be at various dosing levels found to be quite beneficial, having a favorable effects in terms of cancers as well. Coming to the vasomotor symptoms improvement, there is a good Cochrane database systematic review which was published in 2007, showed like, they is found to be significantly improving the vasomotor menopausal symptoms. And there is another publication in Menopause 2008 called HART study, which is found to improve both vaginal, endometrial, and reproductive hormone findings, and showing that dietary soy products are found to be significantly improving the vasomotor symptoms. Here is just in a small box, which is shown that phytoestrogen similar to 17-beta estradiol with the chemical compound synadin is found to improve the cognitive function, which has been studied in Alzheimer's disease also. Next slide, please. But what is the limitation with this is like, the most trials which has been done has been quite small in size and shorter in duration, on average between like 12 weeks or so. The maximum number of duration has been 52 weeks or so, but they are all very poor in quality. And many trials found to have various confounding variables, and there was little concordance in dose or type of isoflavones trialed. And the bioavailability, what has been used in various trials, has been kind of individually variable also. And looking into the actual clinic, in actual practice, the quality and the purity of the products available in the market has been quite variable. Next slide, please. The other important phytoestrogen to mention about is DT56A, which is commercially available as tofu pill or famara. This is another soy prepared derived preparation, which has a phytoselective estrogen receptor modulator like properties, like the other synthetic version of SERM is like a raloxifene or so. It has found to reduce significant menopausal symptoms when it is used in different dosing. A dose which is used at 344 milligram per day is found to improve the vasomotor symptoms, and a dose which is used at 644 milligram per day is found to have a beneficial effects on the BMD. And this has been published in quality journals as well. The commercially available and which is widely used by obstetric and gynecology colleagues have been the preparation called Femoral, which has been available globally. Next slide, please. These are all the preparations which are commonly used. Just by speaking to my friends and colleagues of gynecologists, like, they have been using Menopase, which contains isoflavones, and these are all the vaginal creams, which is estriol cream, available as 15 cream with a concentration of 0.1% or so. And ephemeral, as I said, with the DT56, these are all the various preparations which is commonly used in the practice. The other complementary therapies to mention is like St. John's wort, which is very widely used in Western population, which does believed to have both the serotonergic and dopaminergic effects, SSRI type of effect. If it is indicated, it is used in mild to moderate depression. If it is efficacious, the effects can be seen within 3 weeks of usage. And if there is any kind of significant side effects, which can be seen within 2 weeks of start. But it has to be very cautiously used because it may cause like, it interferes with CYP450 inducing drugs. When it is used, we need to be quite cautious with that. And ginseng is the other very commonly used, which is used for vasomotor symptoms, but again, very cautious because used to interact with drugs like warfarin and also found to cause most menopausal bleeding. The other commonly used are black cohosh, but in the literature, there are contradictory reviews saying that it is beneficial and also having the other view as saying that it is not as beneficial as a placebo. The other commonly used herbs are ginkgo biloba, hops, licorice, which are very popular, but there is no good evidence. And the other very commonly used in our practice is the evening primrose oil, which is very widely used, but no evidence for its efficacy has been seen in menopausal symptoms. The other Indian herbs are like dietary herbs like fenugreek, cinnamon, saffron, fennel, cumin, ginger, turmeric, and so on. So the Chinese herbs, which is the most commonly used one, is duanguai, which has been available as capsules, but it is found to have a significant drug interaction with the warfarin and also found to cause photosensitization. Next slide, please. Beyond this phytoestrogen products, the other complementary alternative therapies which can be considered is cognitive behavioral therapy. These mind-based therapies are particularly useful for dealing with the anxiety and panic attacks associated with the menopausal symptoms. They help to deal with the hot flashes and night sweats positively in bit-sized fashion where patient can digest and cope with it. And there is published articles in various reputed journals also about this. Next slide. So in conclusion, like this complementary alternative therapies are most widely used even in US population too, and particularly with reference to Indian subcontinent, but not all are found to be very safe. So women has to be particularly informed about the risk and the benefits. As Dr. Ekta has mentioned, like we need to have an open communication where that patient can disclose their symptoms and whatever other treatments they have been taking already. So, and also looking into the benefits of the phytoestrogen products, like future research should focus on large, rigorously designed trials where it can look into the safety and efficacy of the common modalities, which are usually widely used by the women to treat their menopausal symptoms. And thank you very much. I conclude here. Thanks for patient listening.
Yes, Dina, you can go on.
I think it was a really good session. We learned about female sexuality by Dr. Ekta Kapoor, and I think the agendas that she brought up were very important. And in fact, it is true that it is very difficult for women to discuss such things pre or perimenopausal, and definitely perimenopausal women in our society have lots of issues about it. And it's a good idea that we actually ask them about it then rather than wait for them to talk. And lastly, Dr. Radhika's talk was good. We know that we have been facing these issues where we have lots of things in the market and we don't know what is safe and what is good. Thank you so much for such a good presentation where you so well placed, so we are clear about these things. And now I think we can move on to the next session.
The next session is about a good debate. We know that whenever we write postmenopausal hormonal therapy, the biggest challenge is most of the patient will decline, saying that this may be associated with breast cancer. There's a lot of debate regarding whether there is actual increase, particularly with the modern hormonal therapy for menopause or not. So we have a very interesting debate here. So the risk of breast cancer with menopausal hormone therapy, is it a hype? So there are two good speakers. We have Dr. Soumik Goswami, who will be talking in favor of this proposal, and then Dr. Sunil Kota, who will be going against the motion. So Dr. Soumik Goswami, can I have his CV slide first? So he is a DM in endocrinology and working as assistant professor of endocrinology at Silkar, Nilaratan Silkar Medical College, Kolkata, and is treasurer Endocrine Society of Bengal, 61 publication in peer-reviewed journals, IGM reviewer for 2019, and invited speaker in various regional and national conferences. So Dr. Soumik, you can start going for the motion.
Thank you, sir. So shall I start sharing my slide?
Yes, yes.
Okay. Is it visible?
Yes.
My screen visible, sir? Okay,
Yes.
thank you.
Make it full screen.
So very
Yes,
good
yes,
evening.
yes, yes.
Thank you. So very good evening to one and all. If we remember, a little less than 2 years ago, Patanjali Ayurved launched a drug called Coronil as a cure for coronavirus disease. And within 4 months, because of the media hype, it sold 250 crore rupees worth of Coronil. So that is what media hype does. It sells a placebo and it unsells an excellent drug like it causes breast cancer. Yes, it's media hype rather than medical reasons that menopausal hormone therapy has gone into disrepute. To look at basic things beyond debate, menopausal hormone therapy is not the same as oral contraception, and most modern menopausal hormone therapy regimes contain much different doses of estradiol and contain dihydrogesterone and progesterone as the progestogens rather than what is present in the OCPs. And if you look at women who are candidates for MHT, usually it's not used beyond the age of 60 years. And all of this is important, as we shall soon see. Now, as I said, it's media hype. On 9th July 2002, JAMA, with its well-oiled media machinery, sent out a media invite saying that we are stopping a trial. It was only 7 days later that it was actually published in JAMA. So a press briefing even before the publication. And the next day it was out all over the world. The Women's Health Initiative was said, I said said again because I'll come to it soon, said to increase the risk of breast cancer. Again, if you look at the Women's Health Initiative, the average age was 63 years. Only 20% of women were between 50 to 60. It was an age where we don't use MHT now. And the MHT used had high dose medroxyprogesterone acetate. We use different progesterones now. Even if we exclude all this, and if we go back to the Women's Health Initiative, what did it show? If you look at the risk of breast cancer, the unadjusted lower limit of confidence interval was 1, and the adjusted was 0.83 for breast cancer. So there was actually no statistical increase in the risk of breast cancer in the trial which began it all, the Women's Health Initiative. So it was all media hype. And we know that there are damned lies and there are statistical lies. So this actually was a misrepresentation of statistics which created this hype. If we still, for argument's sake, consider that yes, it does cause breast cancer, what's the relative risk? The relative risk of having a breast cancer is more if you are a flight attendant, if you are obese. So do we ask someone to lose weight particularly to reduce the risk of breast cancer, or do we discourage people from flying or going into the airlines profession to reduce the risk of breast cancer? We do not. What about CEE? The Women's Health Initiative had clearly shown that estrogen alone reduces the risk of breast cancer, but it was conveniently brushed under the carpet. Moreover, a reanalysis of the Women's Health Initiative published 4 years later showed that there was a big confounder. If you removed prior hormone therapy, women in the Women's Health Initiative receiving combined HRT did not have an increased risk of breast cancer. So it was cleared at this stage, but the damage had been done. The media made a U-turn, as it often does, but we know that a truth doesn't get a chance to put its pants on before the lie travels halfway across the world. So it fell into disrepute, MHT fell into disrepute. If you look into modern day MHT, we are using progesterone, dihydrogesterone. Huge data from France, the E3N study, no increase in breast cancer risk with modern progestogens, unlike medroxyprogesterone acetate. Finnish study, more than 2 lakh individuals. Dydrogesterone, modern progestogen does not increase risk. Another French study, no increase in risk with progesterone. So if we say that we get a lot of hypoglycemia and diabetes because we are using chlorpropamide and glibenclamide, it's our fault. Similarly, with modern day progestogens like modern day antidiabetics, we do not expect hypoglycemia. With modern day progestogens, we do not get any increased risk in breast cancer. Even lesser progesterone like norethistron in the Danish cohort did not increase the risk of breast cancer. As I said, the estrogen arm alone in the Women's Health Initiative had shown a decrease in the risk of breast cancer. And when these patients were followed up, not only was there a decrease in risk of breast cancer, but there was a decrease in mortality in the group of patients who received estradiol alone. Interestingly and quite strangely, later a number of studies came up which said that if you use other forms of estradiol, you might increase the risk of breast cancer. Even if they are true, what is the duration of use? Estrogens, if at all it increases the breast cancer, does only after 20 years of use. And as I said, we use hormone replacement therapy usually in less than 60 years old or up to 10 years after menopause. So why on earth would we actually continue using it for 20 years? So practically, it doesn't increase the risk. Who would be the individual at highest risk of breast cancer? Someone with a BRCA1 or BRCA2 mutation. In individuals with these mutations who underwent risk-reducing salpingo oophorectomy, safe in terms of breast cancer risk. So even in high-risk population, modern-day MHT hormone replacement therapy does not increase risk. Naysayers often goes to this big meta-analysis published in 2019 and say that the risk might be 1 in 50 or 1 in 70 or 1 in 200 of breast cancer depending on the preparation. But if you look at the pink highlighted part, the authors of this study themselves were not sure about the association. They said if these associations are causal without being sure, because this meta-analysis included mainly observational study, and we know as obvious from the cartoon, a cause-effect relationship cannot be established from an observational study because there might be a big confounder. Those on MHT in an observational study might be doing annual mammography, whereas those not on MHT.
Soumik, there's some problem with your sound.
Dr. Soumik, please shut off your video.
Soumik, we cannot listen you. Can you do something for your audio?
So I think Dr. Soumik has accidentally, because the video connection got logged out, maybe we can move with the next speaker. It'll take a while to join back. He's logged out right now.
So we move on to next speaker, Dr. Sunil Kota. He'll be speaking against the motion. And Dr. Kota is a DNB endocrinology, consultant endocrinologist, diabetes and endocrine clinic, Behrampur, Odisha. 86 publications, 85 conference abstract, 18 book chapters, CSI awardee for most number of publication in IGAEM. And Dr. V.D. Nagagoda, oration for RSSDI 2014, Best Reviewer Award for IGM 2018, Young Researcher Award in RSSDI 2018, Scope Scholarship for World Obesity Congress, Mexico, September 2019, and RSSDI 2020 Award for Best Innovation in Diabetes Care during COVID-19. So, Dr. Sunil, please start your deliberation regarding against the motion.
Sir, in the interest of presentation, I would be switching off my video so that the presentation becomes a bit hassle-free. Just okay. I would need a hint from all of you that whether it is visible to all of you or not.
It's visible.
Okay,
Make
thank
it
you.
Full.
Yeah. Thank you so much, sir, for those kind words. After those wonderful slides by my dear friend Somik, I'm going to talk against the motion, what exactly it is. So the hormone therapy is being proposed as a fountain of youth, which would be preventing ladies after menopause to develop any disease or the menopausal symptoms. But as we all know, it is as of now restricted to use within 10 years of menopause, provided one doesn't have any contraindication and who has no risk for breast cancer. So I will be taking you through a series of studies. I think some of those have already been quoted by Somik. And at the end, I would not be engaging into a debate. Rather, I would be trying to clear the air what is supposed to be done. The WHI, we all know, JAMA 2002, combined use of HRT for 5.6 years. The relative risk of breast cancer is 1.24 versus what Somik has stated. It is not always after 20 years that the patient develops breast cancer, and in women between 50 to 79 years, which also includes the current recommendation, there is 8 additional cases per 10,000 women over 5 years. And they go on to conclude that greater than 3 years usage is appeared to be associated with increased risk. Not only that, the risk persisted for 7 years after cessation of estrogen plus progesterone. And this subsequent analysis published in Mortiritas in 2006, they have given us 2 relative risks. If you use it for 5.6 years, the relative risk is 1.37. And at the end of overall trial, after 6 years, the relative risk is still 1.17. So this is the study which my dear friend was quoting, the Nurses Health study. It was dissected wisely in Nature Clinical Practice Oncology in 2006, consisted of 28,835 women. And it says more than 20 years is what is required to have a significant increase in breast cancer, and that's what somewhat is against what I'm going to talk about. But then it is even with a shorter duration of usage in patients, in women having BMI less than 25 kg per meter square, you still have a significantly increased risk of breast cancer. And what about this? Does timing of initiation of HRT have any role? Yes, this particular study, American Journal of Epidemiology 2009, says women who initiate combined HRT soon after menopause have a higher risk of breast cancer than those who start treatment later. And I'm going to quote again the same French E3N cohort. It says, if you start EP HRT close to menopause, even if you have used it for less than 2 years, you still have a significantly increased risk of breast cancer. This is the review of 9 studies, 42,000 patients, studied over a period of 11 years by the US Preventive Services Task Force. They say the breast cancer goes up by 8 times more. So they go on to say that for prevention of chronic condition, either E+P or unopposed E is not allowed. But of course, you can certainly use it for relief of menopausal symptoms. The Million Women study, 1.3 million patients were enrolled, and it started in the year 1998, 2018. At the end of 20 years, what we find is that estrogen only more than equal to 5 years use, it is associated with breast cancer. Estrogen plus progesterone, irrespective of duration of usage, is associated with breast cancer, and past use of more than equal to 5 years of use again is associated. So they say, of course, it is a study of 5 years, but then if you look at the forest plot, more than equal to 5 years of usage is also associated with significant increase in breast cancer mortality. So there are a number of other studies. The PEPI study says the mammographic density goes up in 25% of people. The Fournier et al, they say that estrogen plus synthetic progesterone, of course, is associated with excess breast cancer risk. The epidemiological study by University of California, they say MSTUs increase the DCIS, and so is the finding from this Slebowski RT et al in 2010. EP was associated with more invasive breast cancer and more deaths. This is very recent, JAMA 2020. The conjugated equine estrogen plus medroxyprogesterone acetate compared with placebo is associated with a significantly higher risk of breast cancer with HR of 1.28. One important finding is that if the person is hysterectomized and is using only CEE, there is in fact a reduction in breast cancer incidence and death due to breast cancer. This again, my dear friend Somik has already highlighted. 5 years of MHT, the relative risk of estrogen plus daily progesterone is 2, relative risk for 1.4 for who is on estrogen plus intermittent progesterone, and the relative risk of 0.5 when it is once when it is only for people using estrogen only preparation, and the corresponding excess from 10 years would be twice as great. So supposedly a patient starts at 45 years till age of 55 or 60. You can see within 10 years, the relative risk is again 4 versus 1.8 versus 1 in all these 3 preparations. So it is not always rosy. You have to find out the thorns in between. I'm going to take another 2-3 minutes to sum up. This is the Lancet 2019, the collaborative group on hormonal factors. They say that once who starts hormonal therapy at around the time of menopause, they have greater risk of invasive breast cancer. That's what is the current recommendation. And excess risk were greater among current than past users, but some risk persisted for more than a decade, even after the MHT use is ceased. And look at the third sentence. What it says is that the risk gradually gets increased even if you use for only 1 to 4 years, with progressively greater risk with longer use. Few more studies, they say that majority of the breast cancers in Western countries are ER positive. So if you use only estrogen positive, estrogen only menopausal hormone therapy, that also would increase the ER positive breast cancer incidence rates. And of course, obesity, they say, attenuates the breast cancer risk because the estrogenic effect of excess adipose tissue in the obesity counteracts the estrogenic effect of the exogenously supplied medication. Therefore, they say, but they go on to say that lean and obese women, however, similar in the absolute increase in risk produced by addition of a progesterone. So the conclusion from this particular study is that even if you use for less than 1 year is not associated with increased risk, but the majority of the studies which have studied the usage for about 5 years from age between 50 to 69, there is an appreciable increase in probability of developing breast cancer. And about half of the excess would be during first 5 years of current use of MHT and half would be during next 15 years of past use. That would definitely take into account all the current recommendations where we try to go for hormone replacement therapy, the MHT immediately after menopause. And there is little difference in the absolute excess incidence by age 70 associated with starting age 5 years at ages 45, 50 or 55 years. And the takeaway point, I'm going to present the fact before you. How do we decrease the risk of breast cancer? Selecting women with lower risk before prescribing, it is always prudent to evaluate the breast cancer risk. Educate on lifestyle. Physical exercise and losing weight are very important. Treatment with low risk of MHT, yes, as already Swamik has stated, micronized progesterone or dydrogesterone is associated with low risk. And obviously, even if the patient is falling into the low risk category, we are supposed to use our judgment, and the patient should be reviewed regularly. And the guidelines, some of the guidelines, they say that probably once in 6 to 12 months, the patient should be monitored. Thank you all for the patient listening. Now it's over to the organizers.
Thank you, Sunil. And now I'll invite Dr. Swamik for having a rebuttal for one minute.
Thank you, sir. I would say that the only RCT WHI did not actually show a statistically increased risk. It was the work of the media. Observational studies increased risk 8 per 1,000 women. The risk of dying from a road traffic accident is greater in India. So do you not go out because of that? Mortality reduces even in the observational studies. So a drug which actually reduces mortality, like say empagliflozin, do we not prescribe it because of GTI? We know that it will reduce mortality at the end of the day. Modern day progesterones do not cause breast cancer. So like we don't use glibenclamide, similarly we don't use medroxyprogesterone acetate. I would only end with the word that if we believe that a modern day MHT causes breast cancer, I think we should also believe that horses fly to the moon and unicorns exist. It's nothing but a media hype.
Okay. I think we are running short of time. Dina, would you like to add something or summarize the things or make out some conclusion out of this debate?
I think in conclusion, we always have to weigh the good versus the bad, and it is at the physician's discrepancy and his expertise that they see that whether this patient needs it, whether it's safe for it, or whether it's so I think it cannot be a blanket statement, but I think both of them argued really well, and I think that was excellent. And whoever was for and after, I'm for sure we both all have the opinion, so we can go home and think about it.
Okay. So I can say that if the woman is very much disturbed by vasomotor symptoms, and right at the beginning or perimenopausal age, we can consider menopausal hormone therapy, but it should be for shortest possible duration, and we should always use the modern 17 beta estradiol plus the modern dihydrogesterone like progestogens, so that they are safer. And many a times women themselves who are educated, they are very much worried about breast cancer. So I think we need to regularly put them for surveillance of possibility of breast cancer. So with this, we end this session, and now I'll hand over to the moderator for the next session. Again, a very important session, the current considerations for menopausal hormonal therapy. Dr. Shri Devi Patnala will be carrying it over. Dr. Shri Devi is DM endocrinology and consultant endocrinologist, KIMS Hospital, Secunderabad, and Sri Diabetes and Endocrine Center, Secunderabad, and she is invited speaker in many of the national conferences, and we have seen some publications and book chapters written by her. So over to Dr. Shri Devi.
A very good evening. Thank you, sir, for that kind words of introduction. And after that exciting sessions and exciting debate, we all know that menopausal hormone therapy is again a very gray area in the field of endocrinology. So we all know the benefits and risks associated with it. So now I would invite the panelists, Dr. Sudha, Dr. Samanti, and Dr. Parag for this interesting panel discussion on the risks and benefits of menopausal hormonal therapy and the recent considerations what we have. So, so first question would be to, are the panelists ready?
Yes, Dr. Devi, can you please introduce the speakers?
Yeah. So, yeah. First, the slide, please. Yeah.
Can I request?
Please put up the CV slides, please.
Yeah.
Shrikant, please, can we have the CV slides back?
Mr. Minto, can you please reshare the CV slides?
CV slides, yeah. Yeah. Dr. Sudha Sharma, I have the pleasure in inviting Dr. Sudha Sharma. Previous CV slide of Dr. Sudha Sharma, please. Yeah. Dr. Sudha Sharma is the former professor of the Department of Obstetrics and Gynecology at GMC, Jammu and Kashmir. And she is the Secretary General of Indian Menopause Society from 2021 to 22. So currently she is the Secretary General. She is a Managing Committee member of the PCOS Society of India. She is the President of Jammu Obstetrics and Gynecology Society from 2018 to 2020. And she is the Founder President of Jammu Menopause Society. She is the Editor-in-Chief of Journal of Midlife Health and Editor-in-General of other journals as well. And she's a member of National Advisory Board and Journal Committee, Journal of Obstetrics Gynecology of India from 2006 to 11. So Madam is a very reputed speaker and a member of the Menopause Society. So we would like to hear more from her. Next panelist is Dr. Samanti Kure. Yeah, she is a consultant endocrinologist from District General Hospital, Sri Lanka. She is a coordinator of Sri Lankan Diabetes and Cardiovascular Initiative and Sri Lankan Diabetes and Cardiovascular Initiative, founder secretary of Sri Lankan Diabetic Federation, and this is a public arm of the Sri Lankan College of Endocrinologists. Very good to have another speaker from a different country, so we would like to hear from her as well. Next slide of Dr. Parag. Dr. Parag Binwale is a PG teacher and unit head of Kamala Nehru Hospital in Binwale Women's Clinic. He is the vice chairperson of ICOG 2001 to 22. And he is the president of Menopause Society Pune from 2018 to last year 21. President-elect of Pune Obstetric Gynec Society, National Joint Secretary of IMS, Secretary ICOG in the past, peer reviewer of Journal of Obstetric and Gynecology and JMH, and co-editor of 3 books, and he has delivered oration or guest lectures in over 140 Foxy societies, recipient of Dr. C.S. Dawn Prize, AICOG 2008. Welcome you all, sir. Welcome Dr. Sudha, welcome Dr. Samanti and Dr. Parag for an interesting panel discussion about the pros and cons of menopausal hormonal replacement therapy. So first, I would like to ask Dr. Sudha, Madam, do you think that hormone replacement therapy is an elixir of youth for those taking it? And can you tell us how it has evolved over the years? What were the observations? How it has come into practice? Over to you, Madam.
Thank you, Dr. Sri Devi, for those nice words and kind introduction. A very good evening, everyone. I just want to thank the organizers, Dr. Gagan, for inviting me and making me a part of this 2-day CME, 2-day virtual conference. So your question, HRT and elixir of youth. So this question, had this question been put to me, 5 decades earlier, my answer would have been yes. So with that, we go back to history. Menopause and HRT, it was never a topic of discussion few decades ago. You know why? Because you will be surprised to know, as I was, because the female lifespan before 1947 was just 35 years. So where was the time for menopause? So as the life expectancy started increasing, and according to the Census Commission 2011, it has reached to 72 years and maybe more by now. So more and more females started living beyond the age of menopause, and they are spending more than 1/3 of their life in this phase. So they started experiencing their symptoms, the long-term, short-term, all the problems and the diseases, and the health workers, they started facing challenges. That's how the awareness about menopause started after the 20th century. And about HRT, it started in 1960s somewhere, and it gained popularity in 1990s. So at that point of time, the menopause was identified as menopause deficiency syndrome. So they thought that if you give HRT or hormonal replacement therapy, everything would be over. So at the beginning of 20th century, FDA approved conjugated equine estrogen, that is Premarin for hot flashes, and this drug was available over the counters. Anybody would go and buy it. So females would take these drugs thinking that they will maintain their femininity, they'll maintain their youth, and they'll have the regular bleeding pattern. So the feminine movement in 1960s changed the women's status. And what was the concept was feminine forever. So it was in a book by Wilson that became the bestseller. They claimed that menopause is hormone deficiency state, curable, preventable, just take estrogens and conserve the femininity. So, whole of the female, the millions of female, they started taking estrogens. And by the time they reached in 1970s, they started developing endometrial hyperplasia and endometrial carcinoma. So in somewhere in 70s, the concept of giving progestogens as endometrial protectors came, and also the dose of estrogen was decreased. Then in 1988, FDA approved this, estrogens or this HRT as a preventive therapy for osteoporosis. So the concept shifted from feminine forever to healthy forever. So again, the use of HRT increased still further. This, increased further and further till 2002, when Women Health Initiative study came. Million of the women in USA and around the world, they stopped taking HRT, and the message that came from NIH sponsored project that HRT is not to be prescribed for chronic diseases. So now menopause is no more considered as a menopausal deficiency syndrome, and HRT word is not being used. It is the menopausal hormonal therapy and not the HRT. Okay.
Thank you very much, Dr. Sudha, for enlightening us about that wonderful history, how the HRT evolved. So it's very interesting to know how observation has led to all these things. The next question is to Dr. Parag. We all know, sir, that menopausal is a physiological process in a woman's life. So which group of women would we think that HRT would be beneficial? And also, is there any age limit till which it can be used, or is it individualized depending upon the patient's symptoms or whatever? Over to you, Dr. Parag.
Yeah, thank you very much. And first of all, thank you, the Endocrine Society of India, for having Dr. Sudha and I, who represent the Indian Menopause Society here. And both of us are very much pro women's health, so we would look at it rather differently. Well, the reason why we should be discussing menopausal hormone therapy in the Indian context is because, as compared to Westerners, the menopause comes early in our women. So Western world, the age is about 52 to 53, while the Indian women, as per the Indian Menopause Society, the age of menopause is around 46 to 47. Dr. Sudha very rightly pointed out that 1/3 of life of a woman is spent in a hormone depleted menopausal period. So this is the time when women really suffer. Now, when we talk about hormone therapy, there are specific two groups where the hormone therapy has an important role to play. The first group, which is far more common, is women who come to us with recurrent uh, urinary tract infections, atrophic vaginitis, or even dyspareunia. Now, here the choice of therapy is essentially local. So we give them local estrogen cream, which is prescribed to them every day, once application for about 2 weeks, and then maybe twice a week for next couple of months. But the oral therapy or transdermal therapy is important in women who land up with premature ovarian insufficiency. Unfortunately, there are so many young women who undergo hysterectomy and their ovaries are being chopped off. So these are the women who are at a risk of osteoporosis, or they are more prone for getting heart attacks. And these are the women who really need careful assessment, monitoring, and hormone therapy. Now, how to give hormone therapy depends on the clinician as well, and for how long to continue is an informed choice. Now, the Indian Menopause Society says that whenever we are thinking of hormone therapy, we should be giving smallest possible dose, and that too for a smallest duration of time. Now, here we have to assess the patient carefully, do a thorough examination, do cancer screening. There are certain investigations which I'm sure Dr. Sudha will talk later, have to be done and have to be repeated. And once the clinician feels that the woman qualifies for menopausal hormone therapy, then the options are to be given. Now, we do have a lot of oral therapies also available, but I personally believe that the hormone therapy is to be offered to a woman who understands its importance and who is willing to come for a follow-up. So these women should not be left unattended. Now, as very rightly pointed out, even in the earlier debate, that women beyond 60 years or women who are more than 10 years into menopause, we do not advocate hormone therapy at all for these women. Of course, there are quite a few options. I also heard somebody talking about phytoestrogens. Now, there are some nutraceutical preparations which are also available, which have been shown some benefit. In fact, last year, Indian Menopause Society did conduct a small study where some nutraceuticals were found to be quite useful in Indian women. So it is an informed choice between the patient and the clinician.
Thank you, sir. So basically, the major indications are mostly young women with not much menopause age, and vasomotor symptoms and atrophic symptoms of the vagina. And another maybe prevention of osteoporosis. I think this would be the major indication. Thank you very much, sir, for informing us about that. The next question is to Dr. Samanthi. As we have heard from Dr. Parag about the indications of menopause, can you please share with us which group of women we should definitely avoid it, and especially what is the risk of venous thromboembolism? Because breast cancer and all, we have screening tools and all, but unfortunately venous thromboembolism is unpredictable. So what is the risk of venous thromboembolism with various preparations, and what preparations are better in today's generation to decrease this risk?
Dr. Samanthi, you are mute.
Dr. Samanthi.
So contraindications would be any history of breast cancer, endometrial cancer, porphyria, severe or any active liver disease, and any history of thromboembolic disease or any risk factor for thromboembolism. So if there is any past history of venous thromboembolism or any family history of venous thromboembolism or any history of arterial thrombosis, we would refrain from starting HRT in a patient.
Thank you, ma'am. So next question is to
Dr. Sridevi, can I make a comment
Yes.
here? All right. So last year, the Indian Menopause Society came up with a risk assessment tool. Dr. Sudha was instrumental in bringing up that, and through which we have trained our own gynecologists on different aspects of. So we have to assess the patient as far as all these risks are concerned, and choose the patient wisely. That is number one. And secondly, if there is a thromboembolism and if at all, if there is a need to prescribe MHT, I think transdermal estrogen is something which can be considered because that would certainly not pose the risk of thromboembolism in these women.
Yeah, I fully agree with Dr. Parag. First, age has to be there, not beyond 60. And then, non-oral transdermal would be better if at all it has to. In those high risk groups.
Thank you, sir, for that inputs. Next question is to you, ma'am, Dr. Sudha. Are there any clinical examination features or biochemical tests or radiological procedures which we need to do at baseline before starting menopausal replacement therapy, and anything which need to be periodically done in such patients?
Yes, Dr. Sridevi, before prescribing, we really need to discuss in detail. And I agree with Dr. Parag that it has to be given to only those females who really need it. There is some, indication for giving it and who are ready for follow-up. So if we feel that patient cannot come for the follow-up, I think we should not go for MHT. So we need to take a proper history. We have to weigh the benefit over the risk. All the side effects have to be, discussed in detail. We have to take the personal history, the family history, the past history regarding all the comorbidities, diabetes, hypertension, gallstones, VTE, cardiovascular disease or osteoporosis, and history of malignancy, personal as well as in the family is very important. So, after taking a detailed personal and family history, we need to have a thorough clinical examination that would include a general physical examination, systemic examination, and local examination. So in general physical examination, height, weight, waist circumference, BMI, it has to be calculated. So initially, then we have to do the systemic examination. We have to do the breast examination, which is very, very important before we start any, MHT. Then the pelvic examination, very, systematically we have to do the per speculum, per vaginum, and pap smears is an ideal before we start this. And then we have, battery of investigations which are necessary. And then there are certain investigations which we give, in certain conditions only. So in, as a routine in all the patients, when we have to put them on MHT, we need to have their complete blood count, urine examination, blood sugar, fasting, then lipid profile, thyroid profile, which is equally important. Pap smear, I already told you. Ultrasound of the abdomen, whole abdomen should be done. TVS has to be done to see the, the baseline endometrial thickness and the adnexa. Then mammography has to be done to look at the density, because if the breasts are dense and the estrogens, they cause more density, then we have to compare it. So initially mammograph has to be done, and then it has to be, repeated maybe after 3 years if the previous one is normal, 2 to 3 years. And after, doing all these investigations, then you start the menopausal hormonal therapy. Very rightly said, in a smaller dose, you have to build up the dose till the symptoms are controlled. And then you have to call the patient for follow-up. Follow-up initial has to be, this is according to Indian Menopause Society guidelines. After 1 month, we need to look at the efficacy of the drugs and any side effects if the patient is having, and we have to again examine her thoroughly. And if we find that there is a need to repeat the investigations, only then we repeat all those investigations. Otherwise, we call her after 3 months again to see the effectiveness and the compliance of the patient. And every visit we call the patient, we always give her alternate therapy, alternate measures like lifestyle modifications and alternate therapies if But if we feel that she still requires, then we have to give her therapy, and then we call her annually. Then after you call her annually, we, again, we have to do the general physical examination, and we have to be updated with her again, personal and medical history and any problem. We have to do the relevant investigations, again the TBS to see the endometrial thickness, and again discuss with her the alternate therapies. So this is according to this. And I think after 1 year, again, we have to tell her the benefit over the risk has to be assessed. And if she is, ready to take it, and if she really needs it, we should not divide her of this MHT.
Thank you very much, ma'am, for that comprehensive answer. The next question is to Dr. Parag. We all know these women are in the middle age, and most of them do have comorbidities like hypertension, diabetes, hypothyroidism, and altered lipid profile. So, and they will therefore be on many medications. So is there any consideration of drug-to-drug interactions when we start this hormone replacement, menopausal hormone therapy in such women who are on multitude of drugs?
Okay. Now, first of all, whenever such women come to us, we always take our physician colleague or an endocrinologist colleague in confidence, discuss with them, and then decide the further course of treatment. That's number one. Secondly, as Dr. Sudha said, lifestyle modification is something which is extremely important in menopause, and I would say in about 40 to 50% women, changes in lifestyle would have a positive impact, and probably the need of hormone therapy would be reduced. Number three, we have to ensure that the woman continues taking her medication well, does her clinical follow-up well. If she is hypothyroid, then we have to evaluate the thyroid function and then adjust the dose of thyroxine if she's taking to. As far as dyslipidemia or hypertension or even diabetes is concerned, these are not contraindications for offering MHT. So they can certainly be offered, but periodic monitoring of these patients is extremely important. If you're offering local vaginal therapies to these women, of course, they really don't matter what all medications they are taking. But then if they are taking orally, one has to be vigilant about monitoring the medical conditions as well.
Can I add something here?
Yes, yes, madam.
It is has been seen that because of the hepatic first bypass effect, HRT or menopausal hormone therapy raises the circulating levels of TBG. So therefore, it increases the bound fraction and decreases the free fraction of circulating T4. So as a consequence, oral MHT may increase the dose requirement of the women who are taking these, thyroid drugs.
Yes, that we usually see in patients who are undergoing assisted reproductive technology, also who are given all these preparations, they usually require increased dose of levothyroxine.
Yeah. So similarly, in diabetes also, there more insulin sensitivity than the non-hormonal user is there. So additional studies, they need to be done, but it is said that MHT increases significantly insulin sensitivity.
And hypertriglyceridemia is a concern, gallbladder disease and all is a concern with some. So choosing the right progesterone and all is very important, estrogen, to prevent adverse effects on the dyslipidemia as well. Okay.
Yeah. So whenever we are talking about oral, progesterone, the two options that we gynecologists prefer, number one is dydrogesterone, and the second is micronized progesterone, which we advocate vaginally anyway. So the side effects or the ill effects on the lipids are something which can certainly be avoided with these two.
Yes. Thank you, sir. The last question is to Dr. Samanthi. So, do you think that hormone replacement therapy will help in rejuvenating the sexual relationship of which the woman has?
Yes. So I think this was discussed in detail by Dr. Kapoor. So as she said, it's integration of many factors: biological, psychological, relational, and socio-cultural. So we have to address all this, and then in addition to that, we have to look into HRT, and up to 40 to 55% of females report low sexual desire, and 25 to 50% have the vaginal dryness, and there is dyspareunia in about 12 to 40%. So all of this can be avoided by HRT. So we have various preparations. We have the topical preparations, the systemic preparations, and then we can use the selective estrogen receptor modulators, and of course the testosterone therapies as well. So we have to individualize according to the patient's symptoms and use these to alleviate the symptoms.
I just want to add one thing, if
Yes.
Dr. Sridevi, you allow me.
Yes, ma'am.
Yeah.
Please.
See, if we are talking of sexuality and menopause, if we give oral estrogens, they increase SHBG levels, and on the other hand, they decrease the testosterones. So oral is not a choice for, sexual disorders in menopause. If you are thinking of menopausal hormone therapy and sexuality, give her non-oral route, non-oral route, that is transdermal therapy, because oral would decrease the testosterone, and the main problem in sexuality is the decreased testosterone.
Yes, ma'am.
Dr. Sridevi, can I make a comment here?
Yes, sir. Yes.
Right. Okay. Tibolone is one drug which can certainly be used, and tibolone is supposed to increase the libido as well. So menopausal women who especially complain of low libido, tibolone works really well. Of course, it is a drug which should not be offered to women within 1 year of menopause, because it can be responsible for unscheduled irregular vaginal bleeding. But after 1 year of menopause, yes, one can think of using tibolone if there are issues related to sexuality.
Thank you, sir. So there are some audience questions as well. I think Dr. Nilakshi will deal with them. So one question was, is tibolone available in India?
Yes.
Yes.
Yes, this is available in India with the name two companies, they come Leviol and Maxitive, 2.5 milligram.
Yes.
Dr. Sridevi, there is another question from audience. Once MHT started, how long to continue and how to monitor? This question is by Dr. Divya. Would Dr. Sudha please take up the question?
Sure. Once you start the menopausal hormonal therapy, the dictum is it has to be, smallest dose and shortest duration. Earlier it was like this, but now we say that it cannot be a generalized therapy. It has to be a tailor-made therapy. What suits you may not be suiting to me. So it has to be individualized. You always start with a low dose and then you slowly increase it till the symptoms, they are controlled. Then you continue with the therapy and follow up. I have already told you, but it should be minimum possible duration. Beyond 5 years, it is not at all recommended. Beyond 10 years post-menopause, it is not recommended. 60 years beyond, it is not recommended. And looking at all the contraindications, we have to prescribe it. Looking at the risk and benefit ratio, we have to prescribe it. And these days we have, very, very good molecule like 17 beta estradiol. Earlier we were giving CEE. Now we are giving 17 beta estradiol, which is more biologically similar to the hormones produced by the ovary, and the best progestogens, which already have been told by the earlier speakers, which are friendly, with lipid friendly, with the heart friendly, and which are breast friendly.
There is one more question in the audience in the chat box. Which transdermal preparations are available in India? I think it is the transdermal estrogen preparations which doctor is speaking about. Can Dr. Parag please briefly tell us about this?
See, there is a particular preparation called estrogel, which is again a derivative of, the name is estrogel, which is again 17 beta estradiol. So it is something which can be applied on the skin. A few years ago, Dr. Sudha will also remember that there were patches which were available. Though they are still in vogue in the Western countries, somehow they didn't suit our climate, and our women were not benefited with those patches. So they are no more there. And I think there are estrogen sprays also available, which can be used to alleviate the symptoms of menopause. I'll just add one sentence to what Dr. Sudha has said, that after all, to how long to continue is the woman's choice, and as the healthcare providers for women, we should guide them, talk to them, tell them about the pros and cons, review them periodically, and help them make a choice when to stop it. It should not be stopped abruptly, that is for sure.
Yes, sir. Easterdom patches by Novartis were available, but because of the sweaty nature, tropical country, it was not suiting our. Yeah, now they are not readily viable. Thank you, sir. Thank you for the final comments. I thank Dr. Sudha, Dr. Parag, and Dr. Samanthi for their wonderful insights into the current aspects of hormone replacement therapy in menopausal women. Thank you very much for enlightening us. Thank you very much, sir. Hand over the
Thank you.
session.
Thank you, Dr. Sri Devi, and thank you, organizers, Dr. Gagan. Thank you.
Thank you. Dr. Gagan, shall I wind up the session once?
We please have a one concluding
Let's
remark.
have the concluding remarks from the chairpersons, please.
Okay, I think we are running short of time, and so I'll quickly say that everybody contributed so well, and some of the misconceptions were definitely dealt with. So I'll say that again, that postmenopausal hormonal therapy is suited to a good number of women if your choice is good and you are very particular about not giving it to more than 60 years of age or any woman who is past 5 years of menopause. But it's a good choice if you select the right candidate. Many of the women will be definitely helped, and their quality of life will be improved. So with these comments, I think without going any further, I'll ask Dr. Gagan Priya to take over for the next session. We are already almost 20 minutes late in this session. Thank you very much to every speaker and all the moderators and fellow chairpersons. I'm very impressed with the quality of discussions we had in last 1.5 hours. Thank you very much, and good night.
Thank you, Dr. Sushil. Thank you, Dr. Deena, for chairing this session so well, both Dr. Sushil and Dr. Deena, and Dr. Arundhati and Dr. Nilakshi for designing the whole conversation like they were the behind the lens people there. So thank you, coordinators. I would like to invite coordinators for the next session, Dr. Vaishali Deshmukh from Pune and Dr. Nalini Kopale. Please, if you can carry on the session.
Yes, thank you, Dr. Beena, for that. That was an interesting session, and I hope I'm audible, clear.
Yes.
Yeah. Okay. So after that interesting session and after this battling of this COVID pandemic, I think we are again back to our original battle against obesity and diabetes, and obesity tops the list. We are here to have another session on obesity. We know it's achieving epidemic proportions, and it's a complex multifactorial disease. The more you read, the more you realize you don't know it. And the problem is increasing at all ages, right, from childhood to adulthood and elderly also. But nevertheless, in women, it has more implications, especially in terms of reproductive health, cardiac health, cancers, and many more things. And we have a galaxy of faculty members working in this field to discuss various important topics related to obesity. So allow me to introduce my friend, Dr. Nalini. And okay, that was my introduction slide. You can skip that. You can go to Nalini's, yes. So Dr. Nalini is working at Hyderabad, and she's very active in the ESI, and she's the co-organizing secretary of ISBMR. She's the co-secretary of the 4th PCOS annual conference. She's a recipient of the President's Award for services rendered to the ESI, and she's authored many chapters in the endocrine textbook. So over to you, Nalini, for the poll and taking ahead the sessions.
Thank you so much, Dr. Vaishali. It's indeed a very important topic, and then obesity is definitely pandemic. But how much do we know? The poll about technical team, can we have the poll, please? So definitely it matters. How much do we know about it when we are talking about obesity, and in this magnitude? What are we doing to ourselves, and what are we advising our patients? So this is a small poll about knowledge, attitude, and practice that we are doing, what we have, the knowledge that we have, and the practice that we are doing, and what is the attitude towards small, subtle things which have a huge impact. The poll is all about that. Tech team, can we have the poll, please?
Mom didn't get you.
Meanwhile, you can introduce our chairpersons then, Dr. Nalini, by the time the poll questions are in place.
Right. Today, chairing this important session are two of our senior colleagues. Dr. Sanjay Saran is a consultant endocrinologist as an associate professor at SMS Medical College, Jaipur, and he has over 40 publications, and he has published several chapters in international books, and he has done more than 100 presentations in national and international platforms, and he has been awarded by Government of China for excellence in the field of medicine. It's amazing, amazing to have you, Dr. Sanjay, here. And next slide, please. And the second illustrious chairperson that we have here today is Dr. Parag Shah. He is a senior consultant endocrinologist from Gujarat, Ahmedabad. And he is the director of Gujarat Endocrine Center from last 23 years and is awarded one of the most inspiring endocrinologists of India by Economic Times and has more than 50 publications in reputed index journals and is involved in more than 70 multinational landmark clinical trials as PI, and was the organizing secretary of ASICON 2015 Ahmedabad. Welcome, chairs, for this important session. Technical team, can we have the quiz on exercise, please?
Nalini, I think we're running behind time, so let's move on with the first talk, and let me just speed this up.
Yeah, maybe we can take it if time permits. We'll take it in the end.
So the chairpersons can take over to start the session, sir. May I request Dr. Parag Shah and Dr. Sanjay to take over for the next.
Yeah, thank you. Thank you, Nalini, for your kind introduction. Now, so without delay, just we are moving for our topic. So first of our speaker is Dr. Nitin Kapoor. He will deliver a talk on the obesity seeking among women. So Nitin Kapoor, I don't think he require any kind of introduction now in Endocrine Society. So otherwise, we see he's awarded as AR State Gold Medal Award by ESI in 2020, Young Investigator Award by Sri Lankan Endocrine Society, Melbourne Research Scholarship Award, Tamil Nadu, and this Dr. MGR University Gold Medal Award. So he's a lot of awards. AV Gandhi Award also he got. IJM Award of Excellence in Endocrine Writing he got in 2014. So many awards he has. He's right now professor at the CMC Vellore in Endocrine Department. So now over to Dr. Nitin Kapoor.
Sir, I have a slide video of you. Should I play it, sir?
Yes, please.
Please.
Right at the onset, I'd like to thank the Women Endocrine Care team for having me here today. And over the next couple of minutes, I'll take you through this topic as to how women seek care for obesity management, talking about the gender disparity that stays around this area. And I would cover this topic by answering 3 questions. I would answer what, how, and why. What is the problem statement of obesity in women, especially talking in terms of the global context, the Indian setting, and also in terms of our day-to-day clinical practice. I would also talk about how the health-seeking behavior is different in women as compared to men. What are the reasons underlying this difference? What are the factors and how these vary across different stages of a woman's life? And last but not the least, why is it important for us to know this and keep it in mind while managing women with obesity? What is the impact? How do we identify this and the management strategies? So jumping in straight to my first point, and what is the problem statement of obesity in women across the globe? And I think all of us are well aware that obesity has reached pandemic proportions globally. The prevalence of obesity in women has always been on the higher side, but unfortunately, the gap has been increasing. The gap was between 11 and 13% way back in 2016. Now is 21 and 18%. Statistics from India are no different. We know that about 30 to 35% of women in India are either overweight or obese. But the more distressing fact is when we look at the sharp increase in the prevalence, When you look at the NFHS data, and this is data we published last year, where we look at the prevalence of obesity 10 years ago was just 23%, which has jumped up to 36%, an increase of over 55% over a period of 10 years. It's really unfortunate to know that about 50% of women in the state of Tamil Nadu, where I'm speaking from today, have overweight or obesity. Is this just a problem of metros and big cities? Unfortunately not. When we looked at our own data here from the Vellore birth cohort, which is indeed one of the earliest birth cohort data available. And what we saw that in the last 10 years, there's a rampant increase in the prevalence of obesity from 30% to a whopping 70% in women, a much lesser increase in men. Are elderly women spared? And this was another study that we did in the community in postmenopausal women, the mean age here being about 61 years of age. And again, another startling fact, we find that about 2/3 of women in the community, elderly postmenopausal women, healthy ambulant postmenopausal women, have obesity in the community. So cutting a long story short, yes, obesity is a big problem globally in India, across different age groups, across different metros as well as suburbs. What about our clinic patients? And this is data from the Vellore Pediatric Clinic. And what we see that majority of our patients are approaching their 4th decade. Unfortunately, again, 79% of the women who seek care for obesity are women. And against the conventional thinking where we think, obesity is a disease of the rich and, the well-educated, we see that about 46% of these people actually not even completed 12th standard. About 1/5 of them are unmarried. Amongst those who are married, about 1/5 of them have infertility. Overall, the quality of life in these women is also very poor. And this is a study that we did a couple of years ago, looking at health-related quality of life in women. And we find there are different factors that contribute to the health-related quality of life. Overall, majority of the women had poor health-related quality of life related to obesity. But what was an important learning point here is also that the factors that determine the quality of life vary as per the severity of obesity. Maybe something like comfort with food, experience with dieting is probably more important in the less morbidly obese as compared to the physical and the psychosocial impact in those who have very severe obesity. But the matter of fact is, yes, obesity is a big problem today and affects women largely across the world. So why is it that this health-seeking behavior is very different in women? Why is it the prevalence of obesity is so much? And when we talk of health-seeking behavior in general, and this is a study that we looked at in patients with diabetes, in patients with high risk of developing diabetes from the state of Kerala, yes, gender is a very important factor that stands out when we talk of health service utilization, not only for diabetes, but even for hypertension. And in this study, we found that women actually had a much better awareness, much better control of blood pressure, as well as much better compliance to treatment as compared to men. So definitely patients who have diabetes, hypertension, and other chronic disease, gender plays an important role, and women in general tend to do better with respect to the awareness and the compliance. We're talking about obesity, and this is a review paper that we published last year in Journal of Midlife Health, and large part of my talk would be data extracted from this paper. And when we try and study as to what are the factors that lead to this gender disparity, why women are affected more with obesity, and why is it that the health-seeking behavior is so different? Well, there are several reasons. Yes, unfortunately, we do have a big socioeconomic divide and dissimilar literacy rates across different strata of people as compared to men. There are also very different socio-cultural factors, and when we manage obesity in our day-to-day clinical practice, sometimes I feel it is so difficult to change an existing dietary pattern when women seek care for obesity, because they're so homebound with respect to different kinds of social customs that they find it really difficult to change the diet just alone for themselves. And that's why it's important to treat obesity when at least one more family member is present, so that they understand the need of the change for the betterment of the house. where there are different feeding practices in the postpartum period. From a Punjabi background, I can say that, after delivery, there is 5 kg of what is known as panjiri is delivered for the postpartum lady to have. And this may have all the good nuts and all the ghee and all the fat. Well, I'm not saying that's bad to taste, but I think we have to be conscious about the quantum. We have to be conscious about the calories, the amount of fat that one is consuming from that. There are also non-identical thresholds for metabolic complications. Yes, for some things like waist circumference, we have different cutoffs, but some things like BMI, we do not. And if there is a higher risk at a lower BMI threshold, I think that should be addressed. There are also contrasting biological cravings, and this happens because of the hormonal changes that happen, which is either during a menstrual cycle or during menopause. And I think that also makes things very different. There are distinct hormone-related comorbidities. PCOS stands out as a big problem when we talk of the hormonal problems in women and obesity. And overall, yes, there are also divergent customs with respect to the homebound cultures in women. And sometimes, asking for physical activity becomes really challenging for certain communities of women in our country when we want to really address the weight. So we see that there are several factors which impact weight in women, and this happens across the spectrum of their lifetime, be it pregnancy, and the common myth of eating for 2 people during pregnancy itself is something that needs to be addressed. Before pregnancy, using hormonal contraceptive pills, especially progesterone, is something that puts on weight. Limited breastfeeding, especially for working women, menopause, infertility treatment, so many injections that are given at that time, and even polycystic ovarian syndrome and the whole pathophysiology of insulin resistance and obesity that is associated. We see that across the spectrum of a lifetime of a woman, there's several factors that push them across obesity. And to make things worse, when we talk of the Indian phenotype and we talk about our thresholds of developing obesity-related complications at a much lower BMI, I think this becomes even more relevant. A couple of years ago, we did a study in polycystic ovarian syndrome, women with normal BMI, to see what is the prevalence of lean PCOS. And what we find, startlingly, not really, that the difference in glycemic control, difference in lipid parameters and insulin resistance, definitely higher, despite these women looking lean, having a normal BMI, but still having much higher body fat. The visceral adipose tissue you see in patients with lean PCOS is much higher as compared to similar weight control. So yes, we have a different phenotype here in India, and that adds on to the complexity of this obesity-seeking behavior in women. We also did another study between mother-daughter pairs, 300 mother-daughter pairs from the community. Again, there is a genetic component as well. What we found in this study was that mothers who had a higher body fat percentage also had more daughters with a similar higher body fat percentage, and that is also important. So overall, cutting a long story short, when we talk of gender inequality, we see there are certain environmental factors that we discussed, there are behavioral factors, and even genetic or biological factors, all of them ultimately tipping the balance between energy expenditure as well as energy intake, causing obesity in women, which in turn has an impact on several of these parameters, and this forms a vicious cycle. And these again lead on to weight gain, and the weight gain further causes poor biomedical as well as biophysical, biopsychosocial atmosphere for the women, and therefore it causes obesity. So this takes me to the third aspect of my talk and how we look at it from a management perspective in day-to-day clinical practice. Yes, overall, we know that there are more than 150 medical complications that have been listed with obesity. We have several guidelines which talk about how we manage obesity, and more recent guidelines move away from just looking at BMI, but talk about patient-centered outcomes. We have several algorithms which have been suggested on obesity management, but talking specifically about management of obesity in women. And I would say that every woman has a different story to tell as to why they have weight gain. And as physicians, I think we have to understand that. We have to know what is the key reason for weight gain in that particular woman, rather than generalizing that everybody is eating more and walking less, and that's the end of the story. It's not that one size fits all. It's basically a good interview, a good chat with that patient would get you the information that you require. And based on that, you decide on what treatment you have to do. Every patient needs that person-centric advice of diet. You cannot just tell everybody that you have to eat this and you have to eat that, when that's not going to work out in their day-to-day home practices. So you have to find out what is possible, what the patient can do, and what can be followed at home. Recently, we published the South Asian Consensus on Medical Nutrition Therapy for Obesity and Diabetes, and we've highlighted several times the fact as to what can be followed, should be suggested. Today, also research is changing with respect to diet, not only talking about food items individually, but to look at food groups together. It's just not one food item like a vada that has to be avoided. We know that vada is eaten with pav, or if we say chana has to be eaten, chana is often consumed with puri. So we need to know and talk about food patterns rather than just advising that this particular food is good and that is not good. We need to look at the accompaniments, even about exercise, especially for a lot of women who are housewives who've not done much physical activity. Not really expect them to come onto aerobic and resistance exercises in day one. We go slow. We talk about flexibility management, the balance training, and gradually stepping up the exercise prescription. Many of the women who are household often tell, doctor, I'm doing a lot of household work. And yes, that is a lot of work, but how much of that is contributing to calorie loss needs to be understood. And therefore, we need to explain that, yes, you have to take out that half an hour for yourself for that morning walk, maybe a brisk walk, which not only has weight benefits, but many other benefits that are required. Another problem associated with obesity is osteoporosis. Conventionally, we are always taught that as the BMI increases, the bone strength increases, but that doesn't happen when you become morbidly obese. The bone strength starts to decrease, the fracture incidence increases, and after the fracture happens, the healing capacity also reduces. More recently, we also looked at the trabecular bone score and the bone microarchitecture in people, in women who have morbid obesity, and that itself can be very deteriorated. So yes, that also needs to be addressed when you have a postmenopausal lady seeking for obesity care. While managing, yes, we talk of different medicines that need to be avoided. I think one thing that really stands out in women is the avoidance of using that medroxyprogesterone. If it is not required, consultation with the gynecologist. I think it's helpful to choose weight neutral drugs, not only for contraception and hormones, but for all the drugs, even right from starting from diabetes, hypertension, whatever drugs that promote weight gain should be avoided, especially when you're talking of women. Yes, these hormonal pills do a lot of harm. Barrier methods of contraception should be advocated. Yes, bariatric surgery remains the king of treatment for morbid obesity, works as effectively in women, but these newer intragastric devices are also very, very helpful. So I think with this, I would stop, and I would conclude by saying, yes, the pandemic of obesity is huge globally as well as in India. We talk of several factors that affect in a woman's life, which lead on to obesity, which lead on to a different health-seeking behavior related to obesity. But even though this has a huge impact on the medical complications, it also has an impact on the health-related quality of life. Management of obesity, the algorithms look similar, but we need to address the specific reasons, the specific causes, be it drugs, be it management of osteoporosis, be it knowing the cause of obesity in that one woman will help you manage obesity better. I would stop here and like to acknowledge the obesity management team here at CMC Vellore for all the work that we've done. Thank you so much. And
yeah, thank you, Dr. Nitin, for this very nice and very elaborate talk on the obesity in women. So still we have the question. So we got one question in the chat box. So Nitin, Dr. Nitin, can you tell that many of the antipsychotic drugs, which causes weight gain, and other thing is that they cause increase in the appetite. So can you focus on those drugs, what to do in those patients, whether to change the drug or we have something different remedy of treatment in those patients?
So very short answer to that question. One, we choose an antipsychotic drug with the least weight gain. Aripiprazole would be one. And in coordination with the psychiatrist, we need to get that sorted. Second, when we have a patient with obesity with increased appetite, newer GLP-1 analogs do help in reducing appetite. Dietary methods of increasing protein help to curb appetite. So I think both things, one, changing the antipsychotic drug, and second, the appetite curbing measures, both have to be instituted.
Yeah. We will take, I think, Dr. Sanjay, all the questions at the end. Still, we are running behind the schedule. So thank you, Dr. Professor Nitin, for a very nice elaboration of overview of obesity in Indian setting specifically. Now we'll move to the next session that will be on a lifestyle-based management approach in a management of obesity, specifically among the females. So I welcome Professor Carillo for giving this talk. She is a endocrinologist from the city of Mexico, and she's a professor at ULCA medical faculty. She's a member of Mexican Council of Endocrinologists. She is an invited reviewer of the BFJ case reports and is treasurer of the Mexican Society of Nutrition and Endocrinology. I think she's the right person to talk about the lifestyle behavioral changes in the management of obesity.
Can we have Dr. Perla's video, please?
Hello, everybody. I'm Perla Carrillo. It is my pleasure to be with you today in this spectacular Women Endocrine Care Congress in commemoration of the Women's Day. And I'm going to talk about lifestyle-based approach to the management of obesity in women. It is a very interesting topic. I learned a lot while I was preparing the slides. So I hope we have a good time. I'm an endocrinologist. I work at Mexico City in a public hospital. Here are some of my entertainments. And I have no disclosures. It's a general view of obesity, and the World Health Organization talk about numbers. And if we notice, almost the 40% of the population by 2016 were overweight, and almost 15% of the population, almost equal in men and in women, were obese by 2016. As we noticed, the prevalence, and it is a concern, the prevalence of obesity nearly tripled between 1975 by 2016. So it is a very, very concerning health problem. It is more sad that among children and adolescents, this prevalence has risen since 1975 to up to 2016. And the boys and girls were overweight from 4%, and nowadays almost 20% of them are overweight. But talking about obesity, by 1975 was only 1% of the children and adolescents aged between the 5 and 19 years were obese, and nowadays up to 6% of girls and 8% of boys were obese in 2016. But there are some populations like Mexico that there are 30% of the boys and girls population with obesity. Here are some key facts of what we have talked before, but the last point, obesity is almost totally preventable. So we are going to discuss the first topics to cover when you are avoiding some patients with obesity. It seems to be mathematically, but obesity and overweight has been looked like an energy imbalance. So it could be simple to think that if you take less energy dense food, and if you have more physical activity, it's gonna be like magic, and we can get rid of obesity, but it is much more complicated. I'm going to share with you some of the international guides. This is the American Heart Association guidelines. It's a very busy slide, but I want to notice or remark that all the left part of this algorithm is focused on the assess of lifestyle and changes in lifestyle. And the more new or recently released guidelines are those published by the Canadian Obesity Association, where the remarkable points are that this first point is to ask permission to the patient. We have to talk to them and ask them if they consider that the weight is a problem, and if they allow us to talk about that and to help them with that, we have to assess their own story so we can get deep in their cultures and preferences. So in this slide are the recommendation of management of obesity, and the principal points are that nutrition recommendations has to be personalized, they have to be safe, effective, adequate, and culturally acceptable, and also they have to be affordable. We have to take care of all the points of the metabolic syndrome, like BMI and waist circumference, and the targets of glycemic control, lipids, and blood pressure. We have to provide nutritional therapy supervised by a dietitian when it is possible, and in people with diabetes or pre-diabetes. And we have to choose therapies with changes that support best long-term adherence to get our goals. We have to know our patients, if they come from some cities or from rural towns. There are some factors of proximity of food and economical factors that contributes to the best adherence of the therapies. But there are some other chemicals or some other factors that interferes with obesity. I want to mention these endocrine disruptive chemicals, though these are some products that are present in all products and makeup or are containers. There are present also in pesticides, herbicides, and some things that we can't control, but that they are identified as obesogenic. Look, they can be in pesticides, in some pharmaceuticals, in personal care products. So we are exposed all the time to this EDCs, and they interferes with the adipocytes differentiation, and we can gain weight, and they are disruptors of other metabolic lipids and some other stuffs of the metabolic syndrome. I want to be more specific about the obesity management. This is a list of recommendations of the Standards of Medical Care published 2021, and we have to have a specific goal in patients. We have to maintain more than 5% of weight loss, and we are going to achieve this with high frequency counseling. This is more or less 6 months, and we have to have an energy deficit of 500 to 750 kilocalories per day. We have to know the individual's preference and circumstances of the story of our patients. And if we achieve our goals, we have to supervise our patients for 1 year with maintenance programs and monthly contacts and weekly monitoring of body weight. And in some very carefully selected patients, we can use these very low calorie diets of 800 up to 1000 kilocalories per day, but this has to be very special cases. For the physical activity, sometimes we make a recommendation, but we are not so specific, and we have two principal factors. One of it is the benefits of disrupting the sedentary time. All of us, and most of the actual jobs are by sitting, or with our laptops or in the car. So we have to reduce this sedentary time, and we have to get up every 30 or 20 minutes But this recommendation is not going to replace the exercise. We have to be very specific about what is this kind of prescription. We have two types of exercise, the aerobic one and the resistance sessions. The aerobic exercise, we all know that a short walk for a beginning, 5 minutes per day, and then we will rise the minutes per week, and it could be biking or walking or hiking or even swimming. And the resistance sessions were those exercises with dumbbells or kettlebells, or also a bottle of water will help with this kind of sessions. And also flexibility and balance training, just like yoga or Tai Chi, will be very helpful because reduces the imbalance and reduce falls in almost 30% of the patients. And we would have to keep in mind 5 to 7% of weight loss in 6 months. So the Canadian guidelines get a look or catch their eye on the obesity adults, but women living with obesity in the reproductive years, and we have to be very precise with the patients so they could avoid gain weight in the pregnancy up to more than 9 kilos. It is important to prevent obesity and adiposity in the mother during the pregnancy, because it has been studied since 1950. These theories of that when the mother gain more than 9 kilos per pregnancy, the fetus and the neonate become macrosomic and insulin resistant and become in future obese people and with diabetes. So we have to avoid these 2 cycles because the undernourished mother will have a small baby or small for gestational age with insulin resistant, and when in postnatal overnutrition or urbanization media came in this other cycle with altered fuels and inherits the propensity to obesity and hyperglycemia. This is the same thing. I think I'm short in time, but I want to focus that this obesity treatment has to be weight neutral, has to have a weight neutral approach. What does it mean? It means that we have to communicate to our patient that we have to make or increase the physical activity and achieve the weight loss, but thinking about the health benefits, no thinking about the weight loss, because when the patient is also it's only thinking about the weight loss, could get frustrated when they have weight regain and don't have the health benefits. So I think it's everything. It's a quick view. I appreciate the invitation. I love to be with you. And my message for this day is imagine like children, believe like when you're young, create and inspire to other generations. Thank you very much.
Yes, thank you, Professor Kailo, for a very brief but very in-depth discussion about the lifestyle modification it's need in obesity in a female, and specifically during the pregnant female, which is a very common problem in India, where there is absolute overfeeding by the family members and the in-laws and the mothers, and there is a huge problem of macrosomia occurring. So we'll take the questions at the end of the session. I would now like to invite a very close friend of mine, Dr. Shashank Joshi. He's like my brother, who will be talking about the pharmacological management in obesity in the females. So I think Dr. Shashank does not need any introduction. He's like a stalwart and he is a Padma Shri awardee. He is a chair of IDF Southeast Asia. He is a member of COVID-19 Maharashtra Task Force. He is immediate past Dean of the Indian College of Physicians, past President API, Emeritus Editor JAPI, President Indian Academy of Diabetes and Hypertension, past President RSSDI, ESI, IRO, in the past chair of Indian chapter of the AAC. Over to you, Dr. Shashank, to highlight about the pharmacotherapy in the management of obesity.
At the onset, I would like to thank the Endocrine Society of India for allowing obesity, pharmacotherapy, and women to be discussed on the eve of two important World Days which come back to back. On 4th of March is the World Obesity Day, which had a theme, everybody needs to act. And now, of course, we are in the Women's Day, where we are today, the topic allotted to me is pharmacotherapy of management of obesity in women. That's really the core focus, and I thank the entire team which has invited me to give this presentation. I'm grateful to them and thankful to them. And my namaskar and salute to all the women on planet Earth. They are the superior biological and endocrine sex. So let me quickly have an overview of prevalence of obesity in India and in women. Is there a gender change or a gender bias? Is there a challenge or a difference between pathophysiology of obesity in women? Are there beneficial effects from the evidence-based world on weight management of women with obesity and pharmacotherapy of obesity? So those would be the 4 points in the brief time allocated to me. So we all know that there are probably more than 135 million people living with obesity in India. It accounts for 1/5 of the world's population. 30% of urban children are impacted. And the growth in the next 3 decades is threefold. And the gender issue, which we are going to discuss today, is more than 20% of urban women, all women, 20%, 1 in 5 women are impacted by 2040. Clearly, when we look at prevalence of obesity in the Indian woman, by the National Family Health Survey 5, it is 1 in 5 by 2015, has risen now to 1 in 4. And therefore, the estimate is 135 million people are affected with obesity, and the prevalence of obesity is expected to triple in India by 2040. How is women's health impacted by obesity? We know that due to obesity, there is increased incidence of polycystic ovarian syndrome, which is the 3rd commonest endocrine condition after type 2 diabetes and thyroid. Infertility is on the rise, gynecological cancers on the rise, and we also know that the outcomes of gynecological cancer in obese women is poorer. And we also know that weight reduction, simple weight reduction, improves reproductive outcomes and reduces mortality. Over and above these gender issues related to PCOD, infertility, gynecological cancers, and poor outcomes, we have depression, obstructive sleep apnea, asthma, cardiovascular disease, hypertension, GERD, stress urinary incontinence, and degenerative joint disorders, which are also very, very impelling and compelling on women's health. So when we look at the link between obesity and PCOS, obesity is encountered in 30 to 70% of PCOS affected women. We also know obesity amplifies and increases the risk of comorbidities like impaired glucose tolerance, type 2 diabetes, dyslipidemia, diabetes, and hypertension. We also know weight loss is the first choice of treatment for clinical features in the obese as well as the thin fat Indian phenotypes. So clearly there is another major issue which is impacting women, which is stress urinary incontinence. We know when the BMI goes up by 5 points, there is a 20 to 70% increased risk of urinary incontinence. And in adult women, this prevalence has gone up almost to 50%. And almost 70% of women seeking bariatric surgery have urinary incontinence. So if you look at it from the diagrammatic representation here, central obesity and increased waist circumference raises the intra-abdominal pressure, leading to stress urinary incontinence or SUI. When it is pregnancy, obesity has a direct impact on outcomes of pregnancy. When the BMI is more than 30, then obviously when you look at the maternal and child health, 28% of women who died are obese. And prevalence of obesity in the general maternity population is between 16 to 19%. So whether it is miscarriage, stillbirth, neonatal death, fetal congenital malformations, gestational diabetes, preeclampsia, dysfunctional labor, or even PPH, these are the impacts of weight gain, obesity during pregnancy. So what happens during pregnancy? With every 5-point basis of BMI, you can see 5%, 2%, and 0.2% with severe comorbidities and morbid obesity. There is a 3 to 10-fold increased risk of preeclampsia, 2 to 8 times increased risk of cardiovascular disease in later life. And the impact on offspring is both small and large birth weight, preterm delivery, stillbirth, cancer, obesity, mental health, cardiovascular disease, obstructive airway, as well as impaired glucose tolerance. Also, we know maternal obesity in this diagrammatic by Chu et al. Clearly shows that higher is the BMI, the insulin sensitivity is blunted, particularly in late pregnancy, and therefore we can clearly see that gestational diabetes, which is omnipresent, and we just celebrated the World Gestational Diabetes Day on 10th of March very recently. You can see that that is another big problem in India. 20% of Indian pregnant women get gestational diabetes, and that is linked to insulin resistance and central adiposity and obesity, which is seen in the Indian woman. Also, obesity is linked to cancer in women. We know that the breast cancer increases because we know in the adipocytes, due to upregulation of aromatase enzyme, there is an increased risk of estrogen receptor positive and progesterone receptor positive breast cancer. In fact, there's a 33% increased risk of ER/PR positive tumors with every 5-unit base point of BMI. Endometrial cancer, because of unopposed levels of estrogen, is increased due to conversion of androgens to estrogens, and the relative risk of endometrial cancer is with every 5 kilogram per meter square is increased with the BMI. Also, the colorectal cancer and esophageal cancer, clearly due to the IGF as well as renal cell cancer, with every 5-point basis of BMI, you can see that there is a statistical increase in colorectal cancer, esophageal cancer, and renal cell cancer. All cancers go up. So what is really the pathophysiology of obesity in women? Is it different from men? Probably we all know obesity is complex and multifactorial. We have hedonic inputs, we have energy expenditure. It's a balance between what we eat and what we spend. And what we eat is determined by pleasurable foods, binge eating, palatable foods, and of course, then we have economic and environmental considerations. And all this impacts the adipose tissue, pancreas, gut, genetics, and medications. But the higher obesity rates is because of the food environment being changing. Because you can see in this graphic that the large portion sizes and the greater meal sizes has increased it, and the leftover eating in women has contributed to that. And women are more susceptible, they are more sleep deprived, they are under more stress, they probably are more sedentary, and the free availability of high energy food of low nutritional value has contributed to it. And all that has led to epigenetic modifications. So clearly, if you see also on the menstrual disorders of women with obesity, clearly obesity impacts menarche and menopause both. The leptin regulates gonadotropin surge, initiating development of the pubertal stages. So earlier onset of menarche, ovarian failure, and increased production of FSH at menopause, all three are directly correlated with higher BMIs. Also, we know the endocrine effects. With obesity, you get higher levels of estrogen, we get decreased levels of sex hormone binding globulin levels, and increased androgen excess as evidenced by increased levels of free testosterone. Insulin resistance is synonymous with production of ovarian androgen, and the stromal tissue of the ovaries has a more androgenic environment. Also, clearly we know that obesity, endometrial hyperplasia, and cancer is linked. We know PCOS is linked with endometrial cancer, and prolonged endometrial exposure to unopposed estrogen will develop a 9% lifetime risk of developing endometrial cancer versus 3% in the general population. So clearly, if you look at mechanisms of obesity linking with PCOS, obesity has adipokine excess or cytokine excess, insulin resistance, obstructive sleep apnea, leading to excess insulin. That excess insulin stimulates the ovarian stroma to make androgens, ovarian dysfunction, and metabolic dysfunction. Also, we know androgen-mediated lipolysis, genome, energy spending, and mental and emotional health, all of them impact PCOS. So clearly, PCOS leads to defects in insulin action and beta cell function, and leads to higher levels of glucose intolerance and type 2 diabetes. So obviously, in women with PCOS, due to the androgenic milieu, and the chronic exposure of higher testosterone levels, the fat distribution is maladapted and it exacerbates particularly in the reproductive age, and therefore there is very high levels of diabetes which is seen. So maternal obesity, clearly you can see that in the early stages, the diet quality will impact the DNA methylation on the oocyte and blastocyte, which will have epigenomic changes and programming of stem cells. On the placentome, you have the transcriptome and epigenomic analysis showing that the nutrient transport, the inflammation, the lipid toxicity impacts placenta. And we also know that the neonatal offspring, due to microbial changes and the microbiome in the gut and the milk composition, impacts neonatal programming. And all that has very good now evidence to show that maternal obesity programs the metabolism, adiposity, and cardiometabolic risk factors in the offspring. And therefore, the developmental origins of adult disease is directly impacted. Obviously, weight management is huge in women with obesity, not for cosmetic reasons. Most women seek care not for health reasons, but for cosmetic reasons. But we need to impact on them and influence on them that 5 to 10% of initial weight can be reached within 6 months, can improve fertility, lower androgens, improve quality of life, improve insulin sensitivity, prevent or remit type 2 diabetes, improve glyco-HB, blood pressure, lipids, and cardiometabolic risk. But beyond that, it can reduce sleep apnea, reduce risk of breast cancer or gynecological cancers, prevent PCOD or fatty liver, improve ovulation, improve stress incontinence, lower dysmenorrhea, and lower degenerative joint disease, including osteoarthritis. So if you look at impact of weight loss on urinary incontinence, in this study by Wing et al., with Grady et al. Did, 70% of women reporting a greater improvement on weekly urinary incontinence just by simple lifestyle. Just by simple weight loss of 5%, you can reduce the stress in urinary incontinence episodes at 6 and 12 months in a statistically significant way. Clearly, on PCOS, you can see that if you lose weight, your insulin resistance drops by 50%, ovulation is restored, menstrual cycles are regulated back and regulated, the diabetes risk factor and heart disease risk factor comes down, emotional health, self-esteem, anxiety, depression comes down, health of child during pregnancy improves, and pregnancy-related complications come down. How does one manage obesity, which is the topic allotted to me? Obesity has three treatment options: lifestyle intervention, which is the key, pharmacotherapy, which has emerged, which is what I have to talk on, and bariatric devices and surgery. So pharmacotherapy, at what time do you consider prescribing an anti-obesity woman for your patient? The obesity guidelines, which Mike Jensen from Mayo has highlighted, is once lifestyle changes cannot reach a healthy weight, to prevent weight regain and have a BMI between 27 to 30 with weight-related complications like sleep apnea, hypertension, or have a BMI above 30, pharmacotherapy is clearly indicated. So the guiding principles of pharmacotherapy for people with obesity is, number one, reinforce patient efforts and set expectations about pharmacological therapy. Do not give unrealistic expectations. Understand side effects of the medications and explain it to your patients, because we have many more options as endocrinologists now. And remember that every patient is different. Not all patients will respond the same way to different treatments. So we need to look at and individualize treatment and pharmacotherapy and care for that individual with obesity. So if you look at globally, there are several drugs available. Some of them are available in India too. And they all modulate either the hypothalamus and the various neurotransmitter apparatus in the hypothalamus, or the pancreatic lipases, or the GLP-1s. So the first agent approved worldwide is orlistat. We all know that it is a lipase inhibitor, available in India, 60 and 120 milligrams. We also have some other orlistat derivatives available, but they have not been very successful because the fat content and the palatability has challenges. Phentermine, phentermine topiramate have been available in the US for appetite reduction. They are available and approved in the US, but not available in India. Naltrexone, glucagon are separately available in India for appetite reduction. They have very good role for appetite control, binge eating, and eating disorders. And we have 3 milligram of liraglutide, which is not approved in India for obesity, but has been tried. But we have 1.8 milligram of liraglutide also available in the Indian situations. So these are the US FDA approved drugs for obesity. Most of these pharmacotherapies have their own role. Whom should we give pharmacotherapy? Well, if the BMI is about 30 or if the BMI is about 27 with obesity related comorbidities, and we want to prevent further weight gain, these pharmacotherapies are anti-craving, anti-depression, and allow you to quit smoking. They clearly have a role in diabetes, pre-diabetes, hypertension, obstructive sleep apnea, PCOD. So if you have that, my first choice is usually liraglutide. If there is diabetes, and then the level 1 grade A evidence is there, and pre-diabetes, the level of evidence is level 2 grade B. The second choice is naltrexone bupropion. It is available separately in India. For diabetes levels, it is level 2 grade B, and orlistat is the third choice. For diabetes, level 2 grade B. So that is the level of evidence and the pecking order: liraglutide, naltrexone bupropion, and orlistat in the pharmacotherapy space. And if still weight management is not possible, we can look at another option. However, if the patient is craving, depressed, smoker, then the first choice often becomes naltrexone bupropion as the first choice. Liraglutide becomes the second choice, orlistat becomes the third choice. We do have now off-label availability of semaglutide orally in India today, but this is an investigational agent as we talk today. So clearly, what is the status of these agents? Well, the lipase inhibitor orlistat thrice a day, it's an adjuvant, particularly when people eat out, and of course you have to give it with multivitamin, and you have to probably look at flatulence as a major side effect apart from oily stains. Phentermine topiramate is not very easily available in India. It is a completely prescription drug. It is leucemia, which is available abroad, not yet available in India. Naltrexone bupropion separately is available in India. Improves satiety and endorphins. Can be used still in craving disorders. I use it separately, both the agents in obesity space, but it's completely off-label. And liraglutide 3 mg is still not available in India, but 1.8 mg is available again as an appetite suppressant. And semaglutide is just made its inroads. All these agents can cause weight loss. All these agents have been looked for long-term weight gain, except for phentermine and naltrexone bupropion or phentermine topiramate. Topiramate is separately available. Naltrexone is separately available. Bupropion is separately available. Most of them can achieve weight loss in around 1/3 to half of the cases, and they are very good for preventing weight regain. They have impact on cardiovascular morbidities. All of them have some adverse events. All of them have some rare adverse events as well. The drugs which have now come up in a big way are liraglutide and semaglutide in obesity management, though not approved in India. 3 mg of liraglutide has been approved worldwide for chronic weight management. And semaglutide is another once-a-week dosing. And the phase 3 step trial of semaglutide 2.4 mg weekly show an 18% body weight reduction. Very, very impressive. And we have one more agent which is coming up, which is tirzepatide, which is in treatment of type 2 diabetes, currently being investigated by the SURMOUNT trial, which also has very compelling weight loss. So if you look at the 3 mg liraglutide and the scale trial, the sleep apnea, scale maintenance, scale diabetes, scale obesity and pre-diabetes, scale obesity and pre-diabetes, clearly statistically significant weight loss, and clearly a compelling advantage on the comorbidity space. Also in PCOS, the advantages use restoration of fertility, improvement of insulin sensitivity, and potentially improving the hypothalamo-pituitary axis. Pregnancy outcome with liraglutide has been very well looked at, and hardly any major challenges have been observed. So it's all about long-term treatment adherence. So remember, when we are looking at women's health, which is our core focus today, it's all about maintaining weight loss, where exercise and pharmacotherapy has a role. So obviously, we recommend pharmacotherapy only in people where nutrition and exercise goals and self-monitoring is a challenge. Therefore, the goal setting for weight loss should be SMART. SMART is a specific, measurable, attainable, realistic, and time-bound measure or a method which ADA popularized to facilitate program and basically weight loss in women. To adhere to weight loss interventions, people really need to take social support, focus on dietary and exercise goals, look at motivational intervention, look at dietary goals of portion sizes, caloric intake, the various frequency and type of cooking, and the various mechanisms of physical activity. So obesity in women imposes a very, very compelling healthcare burden and definitely improves and shortens their lives of health of the woman and the offspring both. Timely obesity management can lead to fewer obesity complications, higher chance of future pregnancy, and fewer health risks to children. Pharmacotherapy plays a vital role in management of obesity, and GLP therapy is now emerging as the most promising medical therapy in this space, who has been clouded with a lot of controversies pre-GLP-1 era. Finally, digital detox is the key. Sleep on time, sleep well. Eat less, eat slowly, eat on time, eat a large meal on the breakfast, moderate lunch and light dinner. Eat right, walk more with 10,000 steps, do some yoga, pranayama and meditation, sleep well and sleep on time and smile. In fact, as I said, I salute all women in this meeting and thank you for a patient hearing.
Thank you, Dr. Shashank. It was very crisp but very useful information. I think now we'll move to the next session, that will is a life of a woman post-bariatric surgery, a case-based approach. And we have got a excellent speakers, Dr. Sandeep and Dr. Vikas, to throw us a light about how the challenging sometimes it becomes for endocrinologists to manage the post-bariatric nutritional therapy, hypoglycemias. Some people do regain the weight. So over to you, Dr. Vikas.
Thank you, sir. If it's all right, if I can do it live, I can share my screen.
Sure.
So I thank the organization We Care, all the leading ladies, to give me this opportunity right on the heel of Women's Day. And, you know, it's a great topic, life of a woman post-bariatric surgery. So I hope all of them will have a very happy, healthy, and active life. That's my goal in all my bariatric patients. And it's a very broad topic. So I will just touch upon some of the aspects, the general aspects of care in women who have undergone bariatric surgery, and then touch upon a few cases to look at the specific role of bariatric surgery and the specifics of care in these patients. So why should we talk about it? Bariatric surgery, like the rest of the world, is very common in India now. It's increasing popularity. Over 21,000 bariatric procedures were estimated to be performed in 2019 in India. And most of these are in women, and most of the ones in women are in those in reproductive age group. So I have patients who have I have done bariatric on right from the age of 16 to 74. So it's a very diverse topic, broad topic, but I will talk about some of the general aspects of care first. So, sir, like you said, you know, there's, we have to look at weight regain. We have to look at the general life of the patient. So what I tell my patients upfront, or the most important part with bariatric surgery, is that it's a journey. It's not a one-stop process, not a one-time thing. Bariatric surgery will really help you. It's almost like coming out of a ditch. But then the weight almost like stalks you, it wants to come after you. It's a stalker. So you really have to keep moving away from it. So bariatric surgery will help you come out of that ditch, but you have to keep making that effort throughout with your new lifestyle, your diet, your exercise. It's got to go on throughout your life because weight always wants to come back. So the key factor really is to understand the process. It's a discussion between me and the patient that which surgery is appropriate and what is the specific care after the surgery they choose that they would need to perform. That's what really prevents complications and prevents weight regain. The follow-up is the most important aspect. So for everyone really, the patient, the physician who's taking care of the patient, it's very important to understand which procedure they underwent. So the 60% of bariatric surgery done world over now is sleeve gastrectomy, and about 20% is Roux-en-Y gastric bypass. About 15% is revision bariatric, and 5% is the rest. So most of our patients really undergo either the sleeve gastrectomy or the Roux-en-Y gastric bypass procedure. It's important to understand the mechanisms, even for the patients, that how these surgeries work. With the sleeve gastrectomy, it's primarily a restrictive procedure with some hormonal changes, reduction in the ghrelin. That's with the resection of the gastric fundus, and there's increased gastric emptying. While with the Roux-en-Y gastric bypass, it's primarily malabsorptive with a combination of some restriction and, of course, a lot of metabolic changes where the food reaches the hind gut quickly, bypasses the foregut, and there is stimulation of incretins, reduction of the anti-incretins. Nobody really knows the exact mechanism for sure, but these are theories that why the surgery works well as a metabolic procedure so quickly, like the day after surgery once the diet is started. The aspects of post-bariatric care can be summarized into diet and exercise counseling, nutritional lab assessment, adjusting the medication for the comorbidities that the patient had before the surgery. And sometimes we have to look at problems such as loose skin and some other issues that may crop up. So the diet is actually very simple. What I tell my patients, it's not very different from what any obese patient needs to follow for the rest of their life. With the surgery, they need to understand that any bariatric surgery would usually cut their portion size in half or less than half even. So if they were used to having 2 rotis before, they would probably not be able to have more than half to 1. They have to give up the love for carbohydrates. Our Indian patients, Indian diet, hame lagta hai, humne roti nahi khai, chawal nahi khaya. It's a problem. This mindset needs to change upfront before surgery, because we know that this is one of the problems in our Indian diet. If they understand this before the surgery, they will have a happy life. If they don't, then it can get frustrating. So the diet counseling is very important. It's not very different, after a month of bariatric surgery, it's not very different from the general diet that an obese patient needs to follow. Exercise, another very important aspect post-bariatric care, and it really needs to be a prescription for the patient. It needs to be specific. Everybody needs a specific prescription fit for them, not a general. I can't tell all of my patients go exercise 150 hours a week. 150 minutes a week. It doesn't work like that. It has to be a specific prescription for them. Brisk walk, we know NEAT, non-exercise activity thermogenesis, is great. Everybody can gradually build up their capacity to walk. My aim, I tell the patients, is that within a month of surgery, you should be aiming to walk 60 minutes a day, whether you start off with 30 minutes and then gradually build it up, of course, based upon the individual patient's capacity. But everybody can do it within a few weeks of surgery. The second important aspect is the nutritional supplementation to prevent any, especially with the malabsorptive procedures, to prevent any deficiencies. They need to take bariatric complete multivitamins. These are high-dose multivitamins, not the usual multivitamins. We still need to monitor for deficiencies, especially with the gastric bypass, either mini or Roux-en-Y gastric bypass, for vitamin B12, iron in women of reproductive age group, vitamin D3, which is very common anyway. So for 3 monthly in the first year, then 6 monthly, and if things are stable, then every year. This is very important with malabsorptive procedures. Managing comorbidities is another key aspect. After bariatric surgery, especially with the gastric bypass, it's almost like treating your gestational diabetes patients, where the sugar may completely, the glycemic control may completely, get better within a day. Typically, patients on insulin after the gastric bypass, the requirement may go down to as low as 20 to 40%. This, of course, depends on their duration of diabetes, their pre-op HbA1c, and several factors. But we prefer to start on a lower dose, monitor it, and if needed, increase the dose gradually to avoid hypoglycemic episodes. Usually, oral hypoglycemic agents can be stopped immediately. Sometimes we need to restart them based upon their glycemic control. The blood pressure, the diuretics need to be stopped. Statins would often need to be stopped. Usually, at least in the immediate post-operative period, need to be held. And then the sleep study can be repeated at 3 to 6 months based upon if they're doing well, if they lost weight, then we may be able to stop their BiPAP or CPAP. coming to the specific aspects of reproductive age group women, pregnancy post bariatric surgery, we know that bariatric surgery improves fertility. It also reduces preeclampsia, improves rate of gestational diabetes. There has been some concern that it may cause some low birth weight babies or IUGR. So general recommendation is that to avoid, especially if somebody's had a malabsorptive procedure, to avoid bariatric surgery for 18 to 24 months, preferably for 24 months. And also because the pregnancy then could interrupt the weight loss process for which they've had the surgery done in the first place. So this is really important. Oral contraceptives have high failure rates, especially with malabsorptive procedures, and the fertility improves. I've had patients call me at 3 months after bariatric surgery. They cannot believe it. They've become pregnant. They've tried before surgery for years. They couldn't, they could not get pregnant. And I said, see, you did not listen to me. So it becomes quite difficult. So this is very important for them to, they may need to follow some other form of contraception. So antenatal precautions, if some, in the post-bariatric patients who have become pregnant, ultrasound screening, particularly with malabsorptive procedures, if it looks like the baby is not, the fetus is not growing appropriately, they may need additional supplementation, high dose, high caloric supplementation, protein supplementation. And we really forget about the bariatric surgery during the pregnancy. Hopefully it's happened after 2 years of the surgery. They would need high dose folate apart from their nutritional supplements, routine bariatric supplements. They would need high dose folate, vitamin B12, iron. Something to be careful in these patients would be that we cannot, for any abdominal pain, we need to have a low threshold to see that they're not having some issues related to the bariatric surgery, like subacute intestinal obstruction. If they're vomiting, it may not just be hyperemesis gravidarum. So they may need to have a low threshold for consultation with their bariatric surgeon. We need to avoid oral glucose tolerance tests, need to avoid non-steroidals and extended release preparations. So I would just touch upon four patients quickly. This is my typical patient. Most of my bariatric patients are actually in this age group, young women, often not married, who she was BMI 42, 26-year-old, PCOS, pre-diabetes. She has the insulin resistance. Sleeve gastrectomy to be a procedure of choice in patients like her, who have a family in the future. So, and her BMI is not very excessive. So it works well in patients like her. Typically, she needs to avoid pregnancy for 2 years. So the second patient is, I will touch upon, is a 45-year-old, BMI 45, type 2 diabetic for 3 years. On oral hypoglycemic agents. So this is a lady who came to us from Kazakhstan, and she was on oral hypoglycemic agents with uncontrolled diabetes, high HbA1c, and she didn't want to start insulin, high BMI. So the mini gastric bypass, one anastomosis gastric bypass, was a great procedure of choice for her. She came back, followed up almost a year after the surgery, and this is her having lost weight, having come off no insulin, only on metformin, with a very well controlled HbA1c, normal HbA1c, and of course taking her twice a day bariatric multivitamin supplements to avoid any nutritional deficiencies. The third patient, going up in the age range, was a 48-year-old lady, BMI 52, with severe gastroesophageal reflux disease and early onset osteoarthritis. So we see a lot of our patients have severe reflux, early onset osteoarthritis, which really becomes a cycle. They can't walk much, they start gaining more weight, they have mental health issues, they start having anxiety, eating disorders, and they tend to get into the cycle of weight gain. So especially with her reflux, Roux-en-Y gastric bypass is a good procedure of choice that we, of course, discuss with her, and she chose. And this is her. She had this, like the Caribbean women, she was having early onset joint pains, hip joint and knee joint problems. And she came to see the orthopedic doctors, who sent her to us for weight loss first. And when she came back almost a year after surgery, having lost a good amount of weight and actually moving much better with much improved mobility. So she lost weight, stopped her PPIs for reflux, better mobility, taking her multivitamins. And her knee replacement could be deferred from that point. Lastly, this is a 55-year-old lady, BMI 39, who was referred by the cardiologist with Pickwickian syndrome and dilated cardiomyopathy. This is her. She was on 24 hours oxygen at home. We started her on BiPAP, started her on diuretics, optimized her for surgery because the cardiologist and pulmonologist felt that there was not much else that they could offer her apart from weight loss, and she was not very old. So she underwent the lap sleeve gastrectomy. And 6 months after surgery, with only 20 kg, her excess weight was not that much also. She reduced 20 kg. She was able to stop the oxygen and came off the BiPAP. So these are the patients who really have a change in the course of their life, dramatic change. She came back without a wheelchair, walking to the OPD. And that's what, more than the weight loss, this is the kind of patient that really is very satisfying in terms of the surgery. So my take-home message is that I would hope that bariatric surgery would lead to a healthier, happier, and fitter life in all my patients. The key really is motivation and understanding of the procedure. The patient needs to play a big role in that. The choice of surgery is very important. So is the monitoring and the follow-up to avoid weight regain and any of the problems associated with bariatric surgery. To finish up on, as it was World Women's Health Day, this is a patient, and she doesn't mind me sharing her picture. I think she's really the epitome of women's health in India now. She came to me, she's from Haryana, and she said, my kids have gone to college. I am 55. I've now 140 kg and want to get my life back. And she underwent surgery and she's gotten down to 90 kg in 6 months. And she's now formed a running group in her village where all of them are doing morning walks, jogging, running. She's running 6 kilometers a day at her age now. So, this is, I think, the new Indian woman who epitomizes the Women's Health Day. So I thank you for this opportunity and welcome any questions.
Thank you, Dr. Vikas, for your this beautiful presentation. So now, can we have questions? So first question to Dr. Vikas. When can a woman plan pregnancy after bariatric surgery, and what you will advise for her?
So I would advise them to wait for at least 18 to 24 months, preferably 24 months. So the weight loss process is not stopped. And specifically, if they've had a gastric bypass or a malabsorptive procedure, it would be better to wait to if the time allows, even beyond 2 years. So we don't look at any, and they need monitoring during the pregnancy, of course, high dose folate nutritional supplements. And they need to inform their bariatric surgeon and their obstetrician that they've undergone bariatric surgery. So they need to be monitored closely for any nutritional deficiencies as well.
Yeah. So, Dr. Vikas, can you tell bariatric surgery whether it is considered safe in some adolescent girl who are having this polycystic ovarian syndrome like that? And what is your experience? Can you tell regarding that? And what guidelines are saying regarding the treatment of this PCOS? Can bariatric surgery be a part of treatment of PCOS?
Yes, although bariatric surgery is not as a first line treatment of PCOS, but we know for sure that weight reduction is central to treatment of PCOS. So, in patients who meet the criteria for bariatric surgery and are suffering from PCOS, yes, bariatric surgery would be recommended. We have the specific criteria of BMI criteria in Asians, more than 37 BMI and 32.5 with comorbidities. So yes, it's still not in the guidelines as a primary treatment for PCOS, but yes, I've had patients who've not, in spite of IVF, who've not had pregnancy, and post-bariatric after a few years have had pregnancies. So yes, it works very well in PCOS, but still not part of the guidelines as in isolation for treatment of PCOS.
Yeah, okay, thank you, Dr. Vikas. Now, question to Dr. Perla. So, for the patient with severe osteoarthritis, what sort of exercise can be recommended?
It's a very. Oh, sorry.
Sorry, I thought yes, please go ahead.
Okay. For these kind of patients, we have to assess with a physiotherapist the real state, maybe the rheumatologist. But if we can help with these patients, advising them a very short or light walk, or maybe we prepare them with cold or warm therapies. It could be just a warm bath before the exercise, and then inviting them to take a short walk. If they can do that, and maybe the raising from a chair first 5 times, twice times a day will be advisable, and then we can use these bands that we can get tied to the chair, and then ask the patient to stand up with these bands a few times, five times twice a day will be a nice opportunity to begin with the exercise. These are some other things like this desk cycles that they can use. Sitting in a chair and using these desk cycles will be useful. And then maybe Tai Chi will be a very reasonable exercise in a short period of time, twice a day.
Okay, thank you, ma'am.
Yeah, question to Dr. Shashank. Can this oral semaglutide can be used in a non-diabetic obese individuals?
Maybe Dr. Shah can give his views if Dr. Shashank is not there, because I'm sure he's been a part of many semaglutide studies also.
Yeah, but there are no big oral semaglutide studies for the obesity. We got a injectable semaglutide studied in a large way for the obesity, but we consider the oral semaglutide as the same efficacy as the injectable semaglutide. So we presume that oral semaglutide also should work very well in a non-diabetic obese individuals also.
So as of now, there is no labeled
indication
for
yes.
use of oral semaglutide. Yeah, so I think there is one more question for Dr. Perla is calorie cutting and cutting down nutritional caloric loss. Does it help all the obese patients, or is it to be advised to all patients? Cutting down calories for all obese patients, does it help? You're on mute, ma'am. Yeah.
No, maybe calories is not the best way to assess our patients. That's why we have to assess the patient personal scenario. We have to ask them the daily diet, and then now we can count down their own carb portions. And then we try to invite them to diminish 3 to 5 portions a day, because more or less it's going to be the reduction. We can get the goal of 500 kilocalories less a day, but we have to count the carb portions with them personally. And then they have to show with some figures and some photographies to know how to count, and then know how they can achieve the goal of these 500 or 750 kilocalories less a day. It could be visual, because some people here in Mexico can't read. So maybe a visual analog calorie count or portion of
carbs count will be useful.
Thank you so much. If Dr. Joshi is around, is he around? Then I can ask him his experience. If he's not, then maybe if you have time for a quiz, we can take it, or we get a final. Can I have 5 minutes for the time, or how are we going in the other session?
Yeah, we have time still. I think Dr. Mohan can take the quiz.
Yes. So Dr. Mohan, yeah, you can start. He's a very young, dynamic endocrinologist, very active at the ESC. And he's been a co-author of the task force publication on pediatric endocrinology, and he has 2 chapters in the ESI manual. He'll be taking you through a quick quiz on obesity. And I thank all the chairpersons and audience over here, and as well as the panel members, for an excellent overview of all the obesity related topics. I would expect that you participate in the quiz so that we get your inputs also into this. So over to you, Dr. Mohan.
Thank you, sir. Thank you, madam. So I'll just share the screen. Hope it is clear. At the onset, I'll just thank the entire team of the Women's Endocrine Group for having helped me as a part of this. So I think the instructions are very clear. So the platform, there is an ask the question box. You submit the answers in one single go in a chronological order. So we have some time for some questions, answers in the end. So at the end of the stipulated time, it will be locked, and the technical team will get back with the place of the winners. So the decision of the team is final. So I think we'll first take the first question. So I'll take each question will be given 15 seconds. It's a very straight questions. So first question is the prevalence of overweight or obesity in Indian women as per the latest NFHS data. So options are A 30%, B 20%, C 35%, or D 40%. So I'll give 10 seconds. So please answer only at one go. Please take a piece of paper and only answer after all the 7 questions are completed in a one single go. So next question. The question 2 is, we have got a terminology which is called adiposity-based chronic disease. It is a new term for obesity, and this is a term which is coined by whom and in which year? Options are A, by Obesity Canada in 2017, by AACE America in 2017. The option C is EASO, or Association of European Association of Obesity Study 2018, or by the American Diabetic Association 2020. So I'll give you 10 seconds. Next question is question 3. The WHO mandated body fat thresholds for diagnosis of obesity are, the options are A 25% in men and 35% women. Option B 20% in men and 25% in women. Option C, there is no difference, 30% in both men and women. Or option D, 27% in men and 30% in women. Again, I will give you 15 seconds for this to think. The next question is question 4. Cagrilintide is a dash-based molecule. So we heard from pharmacology, how molecules were mentioned. So is this A, GLP-1 based molecule, or B, a ghrelin based molecule? Option C is for GIP, glucotropic insulinotropic peptide, or option D, amylin. 10 seconds for this. Straight question. Okay. The question number 5. The least weight gain is associated with which progesterone-based oral contraceptive? Options are A, levonorgestrel, B, dinogest, C, desogestrel, or D, drospirenone. Some studies have been done, and these are 4 groups of progesterone-based molecules. So which class has got, which among these subtypes has got least weight gain as per the data? Second last question, the question number 6. Identify the false statement. The statements are too long, so I'll just take A, B, C, D. So you can see on your screen. A is regarding PCSK inhibitors reducing fasting glucose HbA1c. C is for statins improving bone mineral density. C is for fenofibrates usefulness in diabetic retinopathy. Or D is regarding clofibrate causing both SIADH and diabetes insipidus. So evidence based regarding these molecules and obesity and diabetes. So false statement has to be highlighted. The last question, identify the false statement among these. Again, there are 4 options. You can see A is regarding postmenopausal women having LDL higher, small dense LPL, LPA. Option B is regarding lipocalin-2, a molecule which is reduced in obesity and insulin resistance. Or option C, premenopausal women having lower LDL cholesterol, HDL cholesterol higher than men. Or the option C, option D, ketoconazole is a potential option in familial hypercholesterolemia. We should identify the false statement. So last 10 seconds. Yeah. So I think this questions will be just finished in next. So you should answer in one single go. I will also reveal the answers in the just 30 seconds more. So I think this is the last time in which you can answer in that the box of ask question box. So this should be only the correctly marked ones in the sequence. It will be considered for the.
Dr. Mohan, by the time we wait for the answers, I think I request all of you to log in into the main hall, that is the KD Nihalani hall for the inauguration. The link is put by Dr. Gagan in the chat box. So I think we will conclude this session with the answers which Dr. Mohan will give us. So over to you, Dr. Mohan.
Thank you, ma'am. So the quiz, the first one is the prevalence of obesity, overweight Indian women. It was actually the mention is regarding overweight bar obesity. So both of them have been included. It is 35%. The ABCD or adiposity based chronic disease was coined by AAC in 2017. So that is straight. That is option B is the answer. The quiz question 3, WHO body fat thresholds for diagnosed obesity. Again, a straight remark, that is 25% in men and 35% in women. The question 4 is again a straight one, but it is a very new molecule. It is an amylin-based molecule. As you can see, it is a long-acting, lipidated, albumin-binding, stable agonist for amylin receptor that has got a fatty acid moiety. It's a new one. It is marketed and molecule manufactured by the Novo Nordisk. So it's for the long-acting action, once weekly treatment. So as you know, it's GLP-1 has been clubbed with it, and it's called CagriSema in many studies. So it's used subcutaneous formulation for treatment of obesity and non-alcoholic steatohepatitis. So it's a very new recent update. So question 5, the least weight gain associated with which progesterone-based oral contraceptive? The latest, the 4th generation, that is the drospirenone, is the one which is our least weight gain. So this is already discussed in the presentation by Dr. Nitin Kapoor, showing the various molecules. The combination OCPs and progesterone-based, except the ones which is methoxyprogesterone, are having the weight neutral action. Only methoxyprogesterone has got the weight promoting action. And there is a Cochrane review on this, which has made it very clear that the molecule which is drospirenone based has got very much better beneficial on the weight. So the quiz 6 questions false statement was that PCSK inhibitors actually increase the fasting glucose and HbA1c. Other statements are all true. That is, statins actually improve the bone density. The fenofibrates are useful in diabetic retinopathy, and cofibrate can cause both the SIADH, that endocrine effect on these organs. The last question is regarding lipocalin-2. It is increased in obesity and insulin resistance. Other statements are actually true. And a serendipitous features was that ketoconazole is considered as potential benefit in familial. This is actually a true thing. It is actually a thing. This is the Nature Reviews publication, which had extensively told about the lipocalin-2. So the right answers, this is the right answer key: 1C, 2B, 3A, 4D, 5D, 6A, and 7B. So I thank you all for your participation and support. And once again, kind regards from my side. Thank you.
Thank you so much, Dr. Mohan. And the winner of your quiz is Dr. Soumya Abdul Kalam. So we should clap for her.
Soumya.
Get a prize from ESI eventually. So thank you all for being here and having an excellent deliberation and discussion on obesity. And I request all of you to join us in the KD Nihalani Hall. The link is mentioned in the chat box. Thank you, Dr. Gagan and the whole team for inviting me.
Thank you, ma'am.
Yeah, thank you so much. And just maybe one concluding word from Dr. Sanjay Saran and Dr. Parag Shah at the end of the session, and then we can give a vote of thanks.
I think Dr. Sanjay is not here, but Dr. Parag Shah is here.
Yeah. So maybe on behalf of the entire committee of WeCare, we are starting the Women in Leadership session in the other hall as I speak of now. So thank you so much for an amazing day today, and please join us tomorrow as well at sharp 9 a.m. Now we have the most awaited session of the day, Women in Leadership, with some, really pandering people in the KD Nehlani Hall, and we'll request all of you to join us there. Thank you.
Okay, ma'am. Shall I close the session?